treatment also differs. And in concluding, he made us understand that as patients and survivors, we are all writing our stories. And that the healthcare professionals are serving as guide or supervisors. But it is up to us to be in constant contact with our supervisors to guide us as to how to do it. We want to give the opportunity for you to ask questions. So, Dr. Boachajamai's presentation first, then we move on to our senior dietitian. As for that one, I have a secret because today I'll get a lot of drinks home. Yes, we've been told that as a survivor, the best drink is water. But yesterday I saw people drinking. So today I'll come for the drinks. All right, so please questions for Dr. Boachajamai. Questions for the first presentation. Okay.
Good morning, everyone. My name is Fidelis Sana. I'm from Holy Family Hospital, Tichman. I work at the oncology department at Holy Family. I have a married question. It will touch on the first presentation into the second one. I want to know if there's any advice for patients on chemotherapy with neutropenia regarding their diet. I don't know if my question is clear. On chemotherapy, the patient is neutropenic. How do you advise the patient on diet?
Okay, so for neutropenia, the only thing is infection prevention. Okay, so most often, because sometimes some of for diets that are not warm may have some amount of small microorganisms. For something like fruits and vegetable, if it's not something you are eating, we normally tell that during the period of neutropenia, just withhold it. As much as possible, make sure that your food is always warm or you cook the meal during that period. But once you recover from your neutropenia, you can go back to your normal diet. Yeah.
Thank you. Because of the way the questions are going, I think that we can be asking them concurrently. Yes. So Sister Benedicta also made us understand that as survivors, the best drink, I think it's not even to them alone, because we all carry the risk, is water. And that if you have to take fruits, we should take rainbow color fruit. Is it the fruit or the vegetables? The protein. Both of them, all right. So you shouldn't concentrate on one. And then he said we should be able to wash our vegetables under running water between 2 to 3 minutes before we use, and we shouldn't be afraid. So please, you can ask your questions to each, direct your questions to each of them.
Thank you very much. My name is Susan Yemedi. I'm a survivor and also the treasurer for Breast Society of Ghana. Thank you, Dr. Ajman, for the presentation. I think this is the closest I've come to understanding the issues around genes and the cancer. Personally, I was diagnosed with triple negative with a less than 5% estrogen. Now, when I was really paying attention to your slides. The genetic test was negative. And so for me, my question is, which part failed? Apart from the PL something, the brake or the accelerator. If I was also diagnosed that the BRCA was negative, it's not in my family, nothing.
All right. So when it comes to triple negative, most often you normally say triple negative is one of the difficult. Okay. Okay. All right. It's total.
Yes.
Okay.
And
finish.
then what the risk of recurrence? That one I was reading, and they were saying that when it is ER, depending on what it is, your risk of recurrence is high. I'd like to know what's the difference in that area. Thank you.
Okay. So when it comes to triple negative, to start with, it's one of the cancers that's a little bit difficult to treat because sometimes there are a lot of accelerators. The accelerators I mentioned are the main ones, which is easy to identify and treat. There are other forms of accelerators and brakes. Some of them we don't have treatment options for. so you don't test them routinely. And triple negative is a little bit difficult to treat because apart from like those who are PDL1 or BRCA mutated, it's difficult for you to know which actual accelerator is leading to the cancer growth. But at least one thing we understand with triple negative is they tend to be chemosensitive. So those who really respond to chemo tend to be the backbone of their treatment. So that's one thing about the triple negative. When it comes to the recurrence, majority of the time, how will I put it in simple terms? If you have triple negative, mostly the first 5 years tend to be the crucial part of triple negative because the recurrence tend to be relatively higher. But after 5 years, it sometimes become more protective because a lot of patients hardly fail after 5 years. Even though, so the first 5 years tend to be very critical because if you are going to fail, it tends to occur around 5 years. And I think some few studies have shown that after getting towards 8 years, there's a moderate or a small peak. But afterwards, the risk of recurrence tends to be very low. For that's it. But for hormonal therapy, the recurrence rate tends to be very slow. But it will, irrespective of even though it's slow, as a year increases, still going like your risk tend to be the same. Unlike maybe triple negative, it will rise and just fall after 5 years. But hormonal therapy is slow. So even though you are having few people failing, you are still at risk irrespective of. So it's a little bit, nothing is 100%. Yeah.
Good morning, everyone. Thank you so very much for the opportunity. My question goes to our beautiful dietitian. When she was talking, she made mention of the fact that some people do not do concoctions, blending kakadro plus pepper with hot water, no petutu to be. That was what she was saying. And I didn't get it clear. What she saying is not good or is good. My problem here is that I am a survivor. The things you are saying I should eat, sister Minisika. Mintina hosa. Mami fa anketwa de kaka ngu so chomonom. Eni ye benom pa. Me, that is my main question that I want to know. Is it wrong to do that? Because the things you are saying I should do, how you are telling me to live my life, it is very, very expensive. At the same time, I do not want to die. Can't I go natural? Can't I eat anything? I not pay me to America. Menya me dandelion kakra moringa no ne ade na me di social gum na manom aye me jogging 1 hour bia will I still die and na cancer onye fair.
Okay, thank you for your question. So mostly the whole blending thing, the rationale is I'm flushing my system. So I say, mudi dear mopebia, then you go and drink those things to flush the system. It doesn't work like that, okay? And if you look at the options we gave, most of them are found on the Ghanaian market, like orange, kontomiri, boko boko. Those things are around. You can even cultivate them in your compound. It shouldn't be expensive at all. But then some people will also say, oh, I don't like the fruit, so I rather blend it. So you start blending on Monday, Tuesday, Wednesday, Thursday, you are tired of it. 6 months down the line, you've not had any fruit. It's not consistent. But if you are eating a small fruit every day, that is more consistent. Okay.
Okay, so I think that we are going to do the next presentation. Maybe last one as they are setting up.
First. Okay. We will make it snappy. Our questions will be very snappy. So please, my question is to the nutritionist. She mentioned that when you are diagnosed and you are being, how do I say it? So before you even start with your treatment, the nutritionist must be involved. So what about those of us who
our oncologists didn't involve nutritionists, and now we are surviving. Who nutritionist and Nimkrada. So what's in it for us? How do we benefit from this? That is one. And then two, she said that we could soak fruits in water, and before we wash them under running water. Anamibwa. So can we soak them in salty water before we wash them under the running water? Those are my two questions.
Okay, thank you for the question. So just like the vinegar, the salt also has been shown for antibacterial properties. So if you are concerned about bacteria and other things, then the salt is important. But if you are looking at pesticide, the salt is not going to wash pesticides at all. Now, your question about never seeing a dietitian or a nutritionist in the beginning, it's a journey. Okay, so maybe along the line, you can still pop up. So at survival, and it's not restricted. Oh, but sometimes we give general talks in the OPDs. You didn't have any encounter. Oh, then on behalf of all the dietitians, I deeply apologize. We'll come and give you free talks.
Okay, so mine
Thank you very much. I think
Dr.
that
Wache.
maybe we should also say that we'll reconstitute the multidisciplinary team in cancer care, because from the way you are responding, you've never seen, and you have, yes, so we have to reconstitute. So they should be involved right from the beginning. Thank you. I think that we'll call the next person. Okay, last
Please,
one.
Dr.
Okay.
Wache, you made mention of taking off the ovaries when you did the BRCA, and it is the BRCA positive. Taking off the ovaries, then what happens to our body in case our ovaries are taken off?
The next, what is the name? The next moderator.
So, as I did mention, BRCA comes also increase your risk for other cancers, which ovarian cancer is part of it. So, taking off your ovaries, that's why, and sometimes it's not just the patients, it can also be a preventive for family members. So, mostly they try to have their family early, have all the children that they are, and because they are at risk of the cancer, they decide, okay, let me take off my ovaries, let me take off my breast. I don't know, one person that have done that was Angela Jolie, yes, because she knows she's at risk of developing breast cancer. She rather will go for bilateral mastectomy, and now you can actually do breast reconstruction so that you'll be able to increase your risk of, reduce your risk of cancer. Okay.
Thank you very much. We've enjoyed the session. If you want to leave, you ask a lot of questions. Myself, I have about 5 questions for the nutritionist, but I'll come out here and ask all those questions before the session closes, the day closes. Thank you very much. Prof, I think the next session we have Dr. Augustina Bedu. Yes, to take over. Dog, please, the floor is yours.
Are we going for the cut? She said we're going for this. Are we going for this? We should take which one? Okay. Good morning, everyone. Okay, so this session we are going to have 2 speakers. One is going to give us the screening guidelines, and the other one is going to talk to us about imaging modalities, which one is available. I think as a country, we don't really have a national screening program. We don't have who goes for the screening, at what age are you doing it, and then how frequent are you doing it. Currently, each consulting room is having their own telling you as to which one to go for. So here, as a society, I think we are looking into having and establishing our own. So we have a speaker to speak to us on that. The second speaker is going to speak to us concerning the imaging modalities. Maybe as you are sitting here, some underwent only ultrasound, some underwent both mammography, ultrasound. Some even went through MRI. Others did not. So we want to look into which ones are available, who receives what, and then those at risk, what modality is available for us. So each speaker is going to have 10 minutes. And so when you hear the phone blinking, your time is up. Please, we start with Dr. You introduce yourself when you get here, please. Thank you.
Hello, everyone. My name is Judith. I'm a clinical oncologist at the Kolibu Teaching Hospital. I'll be taking us through the breast screening guidelines. So when we hear screening, it's a tool used to detect disease in people who have no symptoms. So if you've noticed a lump in your breast or changes in your breast and you go to the hospital, that is not screening. So for screening targets those who are asymptomatic. Per GlobalCan 2024, breast cancer ranked first with 2,000 plus deaths. Looking at these figures, they are quite frightening. This is why screening has become very important. My pointer is not working. Please, can you change? Okay. Okay. That's why screening has become very important, because it helps us to detect the disease even before symptoms appear. And once the disease is detected early, it makes whatever treatment options that are offered become more successful. At the end of the day, preventing death from breast cancer. An international study done showed that women with breast cancer who participated in breast screening had a 60% lower risk of dying within 10 years after their diagnosis, and 47% lower risk within 20 years. So these are the breast screening options that we have: a breast self-examination, clinical breast examination, mammography, ultrasound, and MRI. And the recommendation is that every woman should receive breast cancer screening in some form. And the best option for you will be discussed by your physician, and it will be based on your age, family history, and other risk factors. So when we look at breast self-examination versus clinical breast examination, there's a difference. Breast self-examination is performed on yourself, by yourself. So if you are here and you don't know how to perform a breast self-examination, you can see any of the experts and we'll take you through. And if you haven't polished up your technique, I'm sure that we can help sort that out as well, because it has been found to be life-saving. It's very simple. It takes just a few minutes to perform a breast self-examination. And studies have shown that about 40% of women diagnosed with breast cancer actually detected the lumps themselves. So the recommendation is that every woman should perform breast self-examination once a month. And the recommendation is to do that at the end of your period, when your breasts are less painful and less lumpy. Clinical breast examination is performed by a trained health professional, and this is usually done during your regular checkups, typically once a year. And the thing about clinical breast examination is that your health professional might actually pick up changes in your breast or a lump that you might have missed during your breast self-examination. So breast cancer risk is mainly what your risk of developing breast cancer is. And we are all at risk of developing breast cancer. The fact that you are high risk or not does not mean that you are going to develop breast cancer. It just tells you how frequent you should be screened, and the fact that you should become more breast aware. So there are risk factors that are used to assess one's risk, and this is done or calculated using breast cancer risk assessment models. And determining your risk group will help determine when you should start your screening. And the recommendation by the American Cancer Society is that we should all undergo a risk assessment by the age of 25. So these are the common breast cancer risk assessment models we have. So your health professional will ask you questions like what your age is, the age at which you started menstruating, the age at which you started menopause, the age at which you had your first child. If you have anyone in your family with breast cancer, was it a mother or a sister or a distant relative? If there's any male in your family who had breast cancer, the age at which the person in your family had developed the breast cancer, whether there's anyone in your family who had other cancers like ovarian cancers, prostate cancers, etc. So based on the risk assessment model used, your breast cancer risk would be calculated, and you either be stratified as average risk if your lifetime risk is under 15%, or high risk if your risk assessment is 20% or above. Average risk are those without any high risk features. So they don't have any family history, there's no genetic predisposition, and they don't have any personal history of cancer. Just a snapshot of what the international guidelines for those who are average risk is. The Americans start screening at the age of 40 years annually. In the UK, they start around 50 years. And then the Canadians start around 40 years. We currently don't have a national screening guideline. So we'll look at what the Americans do for those who are average risk. From the age of 20 years, the recommendation is that you start your breast self-examination once a month, and then get a trained physician to perform a clinical breast examination from the age of 20 to 30 years, every 3 years. Then after the age of 40 years, you can do your clinical breast examination annually. And then you start doing your mammograms at the age of 40. And then the NCCN guidelines also recommend that after the age of 25 years, you should start your clinical breast examination, and then you should become breast aware. That is, you should know how your breast looks like, how it feels, so that if there are any changes, it can be picked up early. And then after the age of 40, your annual screening mammograms, your annual clinical breast examinations. For those who are high risk, there are those who have the genetic predisposition, so BRCA1 and 2 mutation, a strong family history of cancer, or based on the validated risk assessment model, your lifetime risk is 20% and above. And if you've had radiotherapy to your chest before the age of 30, for example, you had cancer in the early stages of life, and you needed to have radiation to your chest, it increases your risk of developing breast cancer. And then there are other selected high-risk lesions that might predispose you to developing breast cancer. So the recommendation is that you undergo genetic counseling and testing, as we've discussed, and then you start your imaging. For those who are high risk, the recommendation is for you to get an MRI done in addition to your mammogram. And then the risk reduction strategies that we talked about, taking out your ovaries, going for a mastectomy, etc. The screening guideline for those who are high risk is that by the age of 18, you should become breast aware. You start your clinical breast examination 6 to 12 monthly by the age of 25. Then subsequently get your annual breast MRI screening done and your mammograms. For those who are high risk, after the age of 75 years, the decision to continue screening or not will be based on whether you are fit enough, and whether if any abnormality is picked up in your breast, whether you are ready to undergo treatment. I'll leave this to the next presenter to tell us more about imaging. There was a study that was done in Mumbai where they performed 2-yearly clinical breast examination, and they found that doing clinical breast examinations reduce breast cancer mortality by about 30%. So for resource limited settings like we find ourselves in, clinical breast examination has been found to be very useful when it comes to breast screening. Communication and shared decision making. It's very important that whatever findings come up during screening, it's communicated to the woman. They need to know where to pick up their results, what the findings are. And I want to mention that having a normal mammogram does not mean that you are no longer at risk of developing breast cancer. You still need to continue your screening follow-ups. And then having an abnormal finding or an abnormal mammogram does not mean you have cancer. You need to subject yourself for further diagnostic workup to be done. And the next presenter will talk about the pros and cons of the different imaging modalities that we have. For pregnant women, there's no routine screening recommended for them. However, if during pregnancy or during lactation you find any lump in your breast or changes in your breast, it's recommended that you see a trained physician. An ultrasound scan will be done first, and then if there's a need to do further imaging, that will be decided on. If you've been treated for breast cancer before, the recommendation is that you continue with your surveillance mammography, doing your follow-up, the clinical breast examination as recommended by your oncologist. For males who are at a high risk of developing breast cancer, it's important for them to report any symptoms that they notice early, so that proper workup can be done for a diagnosis to be made on time. For those who are 75 years, as I mentioned, the decision to continue screening depends on their life expectancy, how fit they are, and how willing they are to subject themselves to treatment if any abnormality is picked up. So, my time is up. All right. So in summary, mammogram plays a critical role in screening. I think that we should come up with a national screening guideline for ourselves, okay? And then high-risk women need more intensive screening. And as I mentioned, clinical breast examination is very important when it comes to screening, especially in resource-limited settings like we find ourselves. Thank you.
Thank you very much, Judith. So we all realize that there's the need for us to have a national screening program, and I believe that as a society, we need to work on it. So we'll call Dr. Awen to give us the second presentation. Then after, keep your questions. When we are done, we'll have some time for questions.
Thank you, Dr. Mrs. Bedu Pepra. I'm Dr. Inseidu. I'm a radiologist at Kolebu. Today, we'll talk about the photography aspect of breast cancer. So as radiologists, we take the pictures of your breast and then we see whether there's something that we should be concerned about. So screening is important because unfortunately for our women, up to 70% of them come and the cancer is already at stage 3 or stage 4, which is advanced. At that stage, then it becomes harder to treat and the mortality risk is higher. As compared to our fancier countries like the United States, theirs is rather the opposite. About 70% of them are coming at an early stage, which means that the disease is not as fatal as it is in our part of the world. And that is why we need to screen. These are what we have available now as a country. Anybody done a mammogram? Very good. Anybody done an ultrasound? Not necessarily of your breast. Very good. Anybody done an MRI? Very good. So what determines, we are talking about who gets what. Two things that determine what imaging you get is your risk, and Judith talked about your risk. So whether you have a family history of breast cancer, a personal history of breast cancer, you have a gene mutation, all of those things determine your risk. And the second thing is your breast density, which I'll talk about shortly. This slide summarizes everything I'm going to say. It's not a question of, am I going to get a mammogram or an ultrasound and an MRI? You are going to get a mammogram. If you are at an appropriate age for screening, in our country, it's 40 years and above if you're average risk. If you are high risk, then you start screening early. So if you're an appropriate age, you are going to get a mammogram. The question is, am I going to get only a mammogram, or am I going to get a mammogram and something else? So that's the take home. The take home is every woman who is at an appropriate age will get a mammogram. The question is, am I going to get only a mammogram, or am I going to get a mammogram and something else? And that depends on the density of your breast and your risk. So what is a mammogram? It's an x-ray of your breast. Just like you do an x-ray of your chest, your leg, your stomach, we also do an x-ray of your breast. But the one for the breast is a little tricky because we squish your breast a little bit and then we hold it still. Unlike your chest where we just take the x-rays, your breast, we need your breast to be still. And we also need it to be as flat and as thin as possible. So we tend to put it in these two things. And then So these are your breasts, and we tend to press it a little bit, and it makes it a bit uncomfortable. And that's why most people tend to be unwilling to do their mammograms. And why mammograms are important? Most people would rather do an ultrasound. Yes, the ultrasound can see the lumps, but the mammogram can see smaller lumps. And these little dots here, they look like specks of chalk or specks of salt. They are called microcalcifications, which you can only see on your mammogram and not on your ultrasound. So if you did an ultrasound and it was normal, okay. If you did an ultrasound and it was normal, it doesn't mean you don't have these things. And that's why you need your mammogram. So remember, mammogram plus something else, not either an ultrasound or an MRI or a mammogram. So mammograms will see these little specks of dots called microcalcifications. It will see lumps and it will see changes over here. Not all of these are cancer. So just because you have microcalcifications don't mean you have cancer. If you have a lump, all of these things mean we need to investigate further. Now, some of the problems with mammograms. The compression. But in reality, the compression only lasts 10 to 20 seconds per breast. So for every breast, we take 2 pictures, one from top to bottom, one from side to side. And each compression is just 10 to 20 seconds. And this is 10 to 20 seconds of a life-saving procedure that can catch the breast cancer early. I think it's worth it. And most people would describe it as, it's not painful, but it's uncomfortable. So that is mammograms. Now, mammograms and breast density. The density of your breast is not the size of your breast. So it's not about how big or small your breasts are. Your breast has fat, and it also has the things that produces the milk, called the glandular tissue. How much gland you have, so how much milk producing stuff you have versus how much fat you have, determine the density of your breast. Now, when you do your mammogram, fat is black. And cancers are white. Whether it's going to be a microcalcification or a lump, cancers tend to be white. And fat is black. So you can appreciate that if your breast has more fat, then it's easy to see the cancer. So this is somebody with fatty breast or not dense breast. If there's a white cancer here, it's very easy to spot. As opposed to these two, they have dense breast because they have a lot of milk producing tissue, which is white. So if there's a white cancer here, then it becomes harder to see. So which is why these two people with dense breast will need a mammogram, because even though the small calcium, the little specks of salt will be harder to see, we can still see them on the mammogram, but we can't see them on the ultrasound at all. So these two people can afford to only get a mammogram if they are average risk. I'm talking about people who don't have other risk factors. So if you're average risk and your breasts look like this, you can get screening with only a mammogram. If your breast looks like this, you get screening with a mammogram and an ultrasound or an MRI. So somebody with fatty breast, see how easy it is to see this small cancer versus this person with dense breast is all white. Now the cancer is actually bigger than in this person, but it's harder to see. So looking at fatty breast on a mammogram is like this fish in this clear glass versus dense breast. So ultrasounds. And another thing people are worried about with mammograms is the radiation. It is radiation, but it's little radiation. It's just with 0.4 millisieverts. For example, if you took a flight from Accra to London, that's about 0.1 millisieverts just by sitting in that flight. If you walked around just existing for 7 weeks, that's 0.4 millisieverts of radiation. And that's the dose you are getting with the mammogram. So it really is not that bad. Now, ultrasounds, which is what a lot of women prefer. It's more comfortable. It doesn't involve compression of your breast. But as I said, you can't see your microcalcifications on the ultrasounds, but you can see the lumps if they are big enough. So we use it to complement the mammogram in women who have dense breast and whose risk factors are not so high. Then the breast MRI, MRIs use a powerful magnetic force. And it's the most sensitive tool we have for diagnosing breast cancer. So somebody will ask, why doesn't everybody just get an MRI? Because when you're getting an MRI, you're going to be lying down like this for another 20 to 30 minutes on your belly. You're going to be prone, and your breasts are going to be in these things here, and you have to lie completely still. And it's expensive. An MRI over here will run you a few thousands of cedis. Now, it has the highest sensitivity, but we also use it together with the mammogram, because sometimes things that can look very confusing on the MRI can be very simple to interpret on the mammogram. So once again, you don't get only an MRI, you get a mammogram and an MRI. And we reserve it for people who have very high risk, like those with the BRCA mutations. It's expensive, it's not readily available, not all centers provide it. And it's a long exam that requires prone exam. You need to lie prone. And another thing with the MRI, it's so sensitive, it can be too sensitive. So even your normal breast tissue, depending on what time of the month you're at, even those can look like cancer. So MRIs pick up everything. And so it can pick up all sorts of things, and you may end up needing lots and lots of biopsies. So if you don't take anything away at all, your breast density matters, and it contributes to whether you get only a mammogram or a mammogram and ultrasound or a mammogram and an MRI. And the point is to catch the breast cancer before you feel it. So even though your self-breast examination is important, we need you to do your mammogram so that we can pick up that breast cancer before you can even feel it. And then know your breast density on your wrist so that you know whether you get a mammogram and something else, not a mammogram or something else. Thank you very much for your time.
Thank you very much for keeping to time. So I did not introduce myself at first. I'm Dr. Mrs. Augustina Bedu-Pepra, consultant radiologist and the head of radiology at Komfanochi Teaching Hospital. I've been a council member since the inception of the society. I'm glad we are here, and I'm glad for all the discussions that we've had so far. I believe that you've also heard a lot, and we've learned that it's not a one size fits all. You need to know your risk. You need to know which one works best for you. And we need to look into it as a society. I think we should try and maybe have some research and come up with our own policies and guidelines, because we're still always mentioning America or UK, and it's subjective, up to your clinician. The person decides for you, but we want to catch the cancer very early. We don't want to, we want to be able to have lumpectomies and not mastectomy. So we seeing it quite early enough so that the appropriate management can be given to us. I'll open the floor for questions and comments as we end this section. Please, the floor is open. Yes, please.
Good morning once again.
Good morning.
Actually, my name is Dorothy. When Auntie Judith was presenting her speech, she made mention of that when you are out of ovulation and menstruation, that is when you will be able to catch up if something is in your breast. In this case, after my treatment, I landed by force menopause. So I do not ovulate. I do not do anything. I'm just there. So how would I do my self-examination? Thank you.
Okay, so we'll keep the questions coming, and at the end of it all, we'll answer them. So please take note, presenters. Any further questions? Yes, please.
Okay, please, my name is Gifty. Please, I wanted to know, how will I know my breast density? Do I have to visit the clinic or something like that?
Okay, any further questions? Yes. Okay, there's one over there.
My name is Kate. I represent Safe Haven. Okay, as a growing child, my grandmother used to do something to me when I started growing breast. They will use the bankuta to hit your breast. Okay, I've come to realize that breast plays a very vital role as a human being and a woman. So my question is that, is there any program for girl growing children who are growing breasts to go through these programs as they grow their breasts to avoid breast cancer in the future?
I think it comes to having the guidelines, which currently we do not.
Thank you very much. My name is Bridget, survivor. I'm so much concerned about the frequent exposure to the radiation, the X-rays, the mammogram. Okay, just like we detox our bodies, is there a way of getting rid of the radiation? Because we are advised to regularly do the mammogram. She mentioned that it is not that bad, meaning it is bad. So is there a limit to the exposure? Thank you.
Thank you very much. That was a good one.
Thank you. My name is Ellie Plymouth Survivor. Okay. My sister died of ovarian tumor. I think 3 months ago, my sister went for ovarian cyst and mine is a breast. So now, should I have to take off my ovary or what should I do now?
Was it just a cyst or a cancer? A cyst is not a cancer. Cancer. Okay, but yeah, okay.
I wanted to ask how can someone with small breasts have a mammogram done?
Yes, doc. I've heard of PET scan. Do we have something like that?
We even do mammograms for male breast. Male breast. You know, there's male breast cancer too. There's gynecomastia and all that. So we do mammogram for male breast. And the PET scan, yes, it exists. It's usually for you to monitor the progress of your treatments. Usually, maybe you did a mastectomy, it was disseminated. So they want to follow up and see, is it really going, are there some lymph nodes that are cancerous? Then they look at it. Yeah. You did it, okay.
Please, do people with smaller breasts have a lower chance of getting breast cancer?
I think that one has been mentioned already, that it's not the size of your breast or the density of your breast, because even the male breast, they get the cancers as well. So I'll give it to the presenters to answer some of the questions. Then we continue with the discussion, please.
Okay. So the question on when to perform a breast self-examination. So if you are not menstruating, you need to find a day in a month to perform the breast self-examination so that you can be able to follow up and be consistent. So, for example, if you are maybe a Monday born, you decide that maybe the first Monday in every month, I'll perform my breast self-examination. I think if you follow that, that would be quite helpful.
So for consistency, yes. You understand?
So someone was asking, how will I know my breast density? You will only know your breast density when you do your first mammogram. That's when we find your breast density. And then for most centers in Ghana, once you do your mammogram and your breasts are dense, they will automatically do an ultrasound for you. Usually it's complimentary. And then someone was asking about detoxing the breast. Valid question. Valid. But if you were to go to London right now, you sit on the plane and go, and that's 0.1 millisieverts. And we get these gel polishes. These days, they are very pretty. That's radiation. And we are walking through the sun and going up and down. That's radiation. And so the risk...
TV, the microwave, all of them.
The benefit of getting that mammogram far outweighs the little radiation you are going to get, because picking up that breast cancer at stage 1 or stage 2 is potentially going to save your life. And that 0.4 millisieverts, I promise you, you get it just by living your life for 2 months. So you might as well get that mammogram. Okay. So there is no way to get rid of them. No, but if you eat healthy, If you eat healthy, just like the dietitian was telling us about our diet, it's just generally good. Antioxidants help us to, get rid of, exactly. But there's nothing you can do to get rid of the radiation from the mammogram, which is really not that bad.
Let me just add that it has some two effects, the stochastic and deterministic. So if it's accumulating, and already most of you are postmenopausal, and so if there will be any effect, it will be in you and not your children. Okay, and then that one doesn't depend on how much radiation you are receiving. Even you can do one, and if it's going to have a negative effect on you, it will still have a negative effect on you. But we have the principle where we call the ALARA, as low as reasonably allowable. So when we're doing mammogram, we use very fast screens. We use every technique that makes you use a very small radiation so that we don't overexpose you. And then for US, they want to do it every year for the follow-up, and UK wants to do every 2 years. In Ghana, we do not have our own. So there's the need to do our own study and see how best we can also decide on which one works for us as Ghanaians. Okay, all right. Please continue.
And then I think Dr. Mrs. Bedi-Pepper answered the question about the breast size. And then, so no, breast size does not, whether how big or small your breast is, does not really determine whether you get breast cancer or not. However, people with larger breasts tend to have, when you are doing the breast ultrasounds, it makes it less sensitive because then you have a lot of area to work with. And then it's harder to pick up stuff. But otherwise, it's the breast density. And now breast density on its own is now a known risk factor for getting breast cancer. So aside the fact that it's harder to pick up the cancers, that also slightly increases your risk as well. And mammograms in small breasts, as even men get mammograms. No matter how small your breasts are, you can get a mammogram.
Yes, so if your mammogram has been done and you've been told that you have a BRCA C or D breast, it means that it's important you do your annual routine checkups. Okay, and if you've had cancer before, it increases your possibility of getting another one or recurrence. So you have to be diligent with your follow-ups and checks. Yesterday, the whole Kumasi was quiet because one of our big men had some malignancy and had died. The Kumasi was so quiet the whole day. So we need to do our routine checks. We need to do it. There was a day that my husband was not really peeing. We said, come and lie down as a radiologist. Come and let's scan you. Come and let's scan. And to our surprise, he had very bad hydronephrosis, not knowing the prostate. And my God, we said, God, this one would have been something else. So routine checks is very important. Last week, I had someone who had already done a mastectomy, but still had lymph nodes, masses towards the axilla and also around the neck. So even if you've done the surgery and you begin to see lumps and bumps, please report and let them take them out. It's better that way. I'm told our time. Okay. Last one.
Auntie, 1 minute. Oh no, just a few seconds. Is it normal for a boy of 14 years to have lump in the breast? Because my boy is complaining that, yeah.
So if the young boy has a lump and is tender, usually it's gynecomastia, it's nothing else. So you let them go to the hospital. It will be evaluated for the reassurance that there's nothing bad. But if the person is grown up and has a lump, you should check. It can be a breast cancer. Thank you very much. God bless you for this section.
But we are behind schedule, so that's not 10 minutes.
God bless you.
You can choose where you want to. Yes, you can come back here. Auntie, we are coming to exam. We enjoyed the
Because we all now we're doing too much. And also letting
So that the Arwin and the if one will present if there's any the other two things break topics, what we think you are what you have slide and should I give it to you? Work on it. We have to make it. I was thinking we should talk about the three basic modalities. I mean, yes, please. You met with us so, yes, can we know the breast? We're supposed to do some services. The question. I want to start with asking the breast. So, if you have anything, I think it's after the exam, right after the exam. So maybe it's just a one day something. Something else. If that you can pass on every start. You let me know what you already have, or I can think of something that will make it interesting. Okay, great. So, I'll bring that like the one it's still residents, not only from your yes, Stephanie, what is it? Banana. So will you call it what? Should I go? So we plan it now. Yes, because that's why I've been talking about breast. That's how I engage the three of them. So I was thinking when we talk about maybe so I'll come with the we should bring something from I was asking how many hours they may have someone signed for me. They said we should everybody. I think I would try for the like a workshop. So they said that so they said a workshop submission or abstract submission. Workshop submission. Or can we do a workshop on breast? I wanted those doing the breast fellowship to do some. So I'll organize them. Then I'll give you the feedback first. And we do a day, 3 hours. At Wednesday to detect Friday to detect. So I think we have to choose one. Well, they start on Wednesday, then Thursday, Friday. And then Wednesday, Saturday, Sunday. So it's Wednesday, Thursday, Friday. Yes, please. So we work on 24th, maybe after lunch. So just like the other one. So, 24th, or do you want to stay in this? So the last one I joined in so the three of you have the same skill. Maybe with the expected and the actual so if 12% was and the school scale at something towards the other. What's I say abstract? Yeah. Because I enjoy listening to you. How many is doing radiology and communication? I don't know. I was here about this. So that makes yours a little more, you understand? So something like that. And then so you present what you got, and then you present what others have done, what they found. And we take a lot of so that was that's and so Alwyn is doing, we want to look at the pathologies with the masses, especially the chocolate and the looking into their kids, so that she gives us an idea about how those kids how they look at continuity. So what sound because you realize that the lower classes, usually the hospital is so let's talk, and then if one will present that's the add to Yeah, because I'm presenting on so as the big like a teaching session. If you have time, please set up the ones and you have there. It's not teaching. But she's been doing the bars. Yeah, so we just want the correlates. What you can see or not, what you see or not. It's very, very important, but people overlook the everyone is and you are but you can get there. No, not inside the because I want to show, I've been thinking about that this thing, because I want to show you can see that.
Hey, do we have our presenters here? Good morning. We are supposed to have 5 presentations in this first session, but I don't see 5 presenters. Are there 5 presenters here? Okay. I think we have to start, whichever way we look at it. So we are going to have, in this first session, 5 presentations, 5 very, very powerful presentations. Topics like quality of life of women with breast cancer receiving chemotherapy at a tertiary hospital. Is Amos Azuri here? Amos. Okay. What about, who is presenting for Josephine? Josephine's team. Anybody presenting for Josephine's team? Beautiful. All right. So presentation number 1, which is now presentation number 2 on your abstract list, is prevalence of upper limb lymphedema and its impact on the quality of life following breast cancer surgery at a tertiary hospital. This will be done by Cynthia. Is it Cynthia? Cynthia Aklinati from the Kolebu Teaching Hospital. Please, let's welcome Cynthia to give us the presentation. I think we'll take all the presentation, so please note your questions as the presenters go ahead. There's a pointer there.
Next, do I have 10?
All right, 10.
It's not working. I haven't started. I haven't started. What time now?
But you use the microphone.
The pointer is not working.
Is it on the side?
Okay, let me see.
I think point it to them. All right, Charlie, you do the right thing. Okay, so you ask for the next slide. So the previous slide. All right.
Good morning. I'm Cynthia Aklinate, presenting on behalf of the authors, the prevalence of upper limb lymphedema and its impact on the quality of life of following breast cancer surgery in a tertiary hospital in Ghana. Next slide, please. And this is going to be the outline of this morning's presentation. Next slide. Okay. So we've made so many gains in the management of breast cancer, and our champions are surviving longer. And as such, they are getting to experience more of the long-term morbidity associated with the disease itself and its management. Upper limb lymphedema, which is a swelling of the upper limbs, that's your hands, forearm, and arm, due to the accumulation of protein-rich fluid, is a common complication after a breast cancer surgery and axillary lymph node dissection, and this can really affect the quality of lives of the patients who experience it. Before we are able to do anything marginal about it, we would at first need to know how prevalent it is in our setting, and unfortunately, this has been poorly described in Ghana, and this study sought out to define the prevalence of the postoperative lymphedema its associated risks, and assessed its impact on the quality of life of the patients who have it. Next slide, please. So the study was a cross-sectional study done at the Kolebu Teaching Hospital, and women who had undergone breast conserving surgery or mastectomy with axillary lymph node dissection were the participants between the year 2016 and 2020, and data collection was done in 2022. For the assessment of lymphedema, we used the patient's self-reported symptoms of lymphedema or lymph swelling and the objective measurement of having a difference of more than 2 centimeters or more in between the two upper limbs. The measurement was taken at the middle of the forearm and the middle of the arm. And for quality of life assessment, we use the European Organization of Research and Treatment of Cancer Quality of Life tool and the breast cancer specific module to assess that. To find the associations in between the associations for the risk factors and lymphedema, the analysis was done with the logistic regression method. Next slide, please. Okay, so majority of our patients involved in this study, well, we had about 110 patients involved in the study, and majority of them were over the age of 50. And most of our patients as well were postmenopausal. And we had another majority of them being overweight and obese in terms of their BMI. Most of the patients were bigger than having a normal weight. Next slide, please. Again, about 47% of the patients had had surgery for 2 years or more. And then the other fraction having the surgery for less than 2 years or less. Let me put it that way. Most of them, 67% of the patients, like 2/3 of the patients had mastectomy, and 1/3 of them had breast conserving surgery, in that the lump was removed and the breast was left. But all the patients involved in this study had axillary lymph node dissection. And 2/3 again of the patients had surgery on the side of their arm, which was not their dominant hand. In assessing the quality of life, looking at how well they are coping with their life, we noticed that about 50% of the patients had their quality of life above the median score, and then another fraction having their quality of life lower. But looking at patients with arm symptoms, such as the swelling of the arm, the heaviness, the pain, and all that, a higher proportion had the arm symptoms compared to those who did not have it. And about 60% of the patients had lymphedema. Next slide. Okay. So we realized from our study that having a higher age, or patients who had the lymphedema compared to those who did not have, had a higher age. And this was statistically significant, had a statistically significant association with the lymphedema. Most of our patients who were more than 50 had a higher odds, in that they had a higher chance, 2 times the chance of getting lymphedema compared to those who who were less than 50. And again, patients who were overweight or obese also had a higher risk of getting lymphedema compared to those who had a normal weight. Next slide. Again, the type of surgery that was done for the patients had an association with getting lymphedema, even though all the patients in the study had axillary lymph node dissection. Most of the patients who had breast conserving surgery, the risk of getting lymphedema, or the odds of having lymphedema, was higher with breast conserving surgery than with those who had mastectomy. And in our discussion, we were thinking that this could also be to the fact that they all had radiation therapy, which is also a known risk factor for the development of lymphedema. Most of our patients had a good quality of life, in that their quality of life was above average, even though we had a higher number of them still having the upper limb symptoms. Next slide, please. And patients who had a higher stage also had a significant association, a higher stage of disease had a significant association with the development of lymphedema. Radiation therapy, like I mentioned on the previous slide, also had a higher risk of getting lymphedema. And chemotherapy, adjuvant chemotherapy, in this case, patients who underwent adjuvant chemotherapy actually had a lower odds of developing lymphedema compared to those who did not have lymphedema. And patients with more than 16 or 20 lymph nodes removed from their axilla, their armpit, and those who had more than 10 lymph nodes involved with tumor also had a higher odds of getting lymphedema compared to those who had less. Next slide, please. So looking at what the data we collected, we realized that the prevalence of lymphedema in our setting is actually higher than what is documented globally. We had a rate of 59.1. Globally, we have a polled estimate of 21.4. And in lower middle income countries, there's a rate of 30%. The possible explanations for this could be because most of our patients present late. They come with an advanced disease. They might already have lymphedema even before they come for treatment. And in our study, all the patients had axillary dissection compared to the global study where some of the patients had sentinel lymph node biopsies, in that they just went to pick some of the lymph nodes. But in our setting, the whole axilla was cleared. Also, in another study done comparing blacks and non-blacks, blacks had a higher proportion of lymphedema, which could probably have some racial predilection, but this has not been investigated and documented yet. And most of our, all of our patients were blacks in this study. There's also a systematic review that gave a rate of 0.4 to 92% of lymphedema prevalence, which ours falls into. But there's only one of this study that's coming from sub-Saharan Africa. Lymphedema, from all that I've said, we've seen that it's significantly associated with increasing age, patients with a higher clinical stage, and those who have actually noticed swelling of their arm and reported it. Patients who were obese, the type of surgery they had, whether they had radiation therapy or not, having 16 to 20 retrieved lymph nodes and more than 10 lymph nodes involved in tumor, had a higher odds or had a higher chance of developing lymphedema. And chemotherapy from adjuvant chemotherapy in our setting was associated with a lower odds of developing lymphedema. These findings are consistent with international findings as well, as documented in literature, except for the chemotherapy, and even as that as well, actually, because they also have conflicting findings. Some get lower risk of lymphedema, and then some get a higher risk of lymphedema. And the quality of life in our survivors, as we noticed, was actually above the median, even though most of them had the lymphedema. They had the symptoms from the lymphedema, not being able to use the arm as well, the heaviness, the pain and all. And looking at it, the conclusion we could draw from it was that even though they had the symptoms and still had a good quality of life, it's likely our champions have adapted to the symptoms and found other ways to be able to go about it and find ways to do their own things. And because previous studies, other studies done showed that people who had the upper arm symptoms actually had a poor quality of life. But in our setting, it was different. Even though they had the upper limb symptoms, they had a good quality of life. So from our study, like I said, there's only one that was in Nigeria, in the sub-region. And our study is going to add to more information so that we can find more solutions for our patients. And it also underscores the need for routine surveillance and early detection, because when you detect it early, you can manage it better and stop it from getting worse. And we've also seen that our patients are actually able to identify the symptoms. So using the patient's word as a way of screening is also a cheap way of doing it. And we can pick up these things earlier and intervene. And we know that taking a lot of lymph nodes from the axilla was associated with a higher risk of lymphedema. So to the clinicians, as we are now moving towards less radical ways of staging the axilla, it's going to help the patient. And as we keep on learning, we keep on finding out more so that we can help our patients. Thank you very much.
Wow, congratulations. A better hand clap for Cynthia. I don't know if is Amos back here now. Amos. Amos Azuri is still not back. Okay. Our next presentation is on exploring women's perception of climate-related environmental stresses and their influence on palliative care experiences and the quality of life among women with breast cancer in Ghana, a qualitative descriptive study. Naomi's group, who is presenting for Naomi? Is Naomi here? You're not presenting? But your name is here. But who is presenting for you? Naomi, you have to present yourself. What do you guys think? It's Sule is presenting, but it's not here. Okay. Stella, is Stella here? Okay. So we'll be exploring breast cancer examination practices, self-breast examination practices among women seeking healthcare at the SDA Hospital, Koforidua. Let's welcome Stella Ichan Abafwewa.
Thank you. Okay, please. The topic for the study was self-breast examination among women seeking health care at SDA Hospital, Koforidua. Since yesterday's submission, we've got to realize that self-breast examination is one part key for us to catch our cancers early so that prognosis will be good and survival rate will be high. Please. Yes, where they go? Okay, thank you. So the rationale behind the study was that breast cancer remains a major global problem. And for us to, as said earlier, for us to catch it early, we need to do something. And self-breast examination is a practice that is not expensive, and we can do that for ourselves. So the study focused on exploring or getting the awareness in the population, the knowledge and practices and associated factors that was related to they practicing the self-breast examination or not. Please, next slide. So we sampled about, our population was 274 women. That was age 18 years and above. The study was cross-sectional and we analyzed it with data. Questionnaires were distributed and the chi-square test was used in determining the association between the social demographic factors and the practices, as in were they doing it, how were they doing it. Please, let's go to the next slide, please. So from the study, we got to know that 84.7%, they are aware of the practice. They do it. But then 50% of the population had poor knowledge of proper techniques, as in how they should do it. And 76.3 reported doing that, as in, yeah, but how do you do it? It's not consistent. And the gap was 8% perform that monthly. And we know that with the self-breast examination, every month we need to do that for the consistency. Those who are still menstruating, you do that after your menstruation period, that is 2 to 3 days after. Those who are not menstruating will find a day in the month for them to do it, and it should be consistent. As in, if you take it like the way we heard from our earlier submissions, if you are doing it every Monday in a month, that means you should be consistent and do that every Monday so that we'll get to find what is happening in our breast. Then we'll catch it early and report to the facility for further investigations. Please, let's go. So this was it. From the research, we got to know that those who had a little bit of education were exposed to the practice, as in they've heard it before. And also employment status, those who were doing it were those who were having jobs and those who were also married. So these were the significant factors in it, as in those who have gone to school, they've heard of the practice, they are doing it. Those who are working and those who are married. Please let's move. So, what did we notice? We noticed that the lack of knowledge, that is, in the aspect of healthcare provider education, when they come to the hospital, they are not taught how to do it. We don't do the constant education at the OPDs. So they've heard about but how do you do it? They don't know it. So they just do it anyhow. But they've touched, if you ask, they said I've touched it before. So that is it. And time constraint, I don't have time. I'm in a hurry. So I don't do it as is required. But that is what they say. Please let's move. So in conclusion, the take-home message is that awareness and reported practice were relatively high, as in they are aware of self-breast examination. But how to do it is the problem, and the consistency is also the problem. So now, as clinicians, we are also telling ourselves that when they come to us at the OPDs, we should go extra mile by teaching them or talking to them about the self-breast examination. Apparently, some have heard it from relatives and others, but for they themselves being educated by a clinician, they've never been taught of that. And we should also inculcate that in our practices so that we could catch the cancers early, and now prognosis and survivorship will be great. Thank you. That is all.
Please, a better hand clap for. Do we have any of our previous presenters here? Sule and Amos. Sule is not here. Naomi should still present, Anna. I'm not with you. But still. All right. So it's Rita here. Rita absent. Yeah, I mean, we can't keep waiting. All right. So that brings the first session to an end. If you have any questions, can we get the presenters in front here, please? Come and sit somewhere in front here. Presenters, Cynthia and yes, thank you. All right. So the floor is open for questions, but because I'm with the mic, I'll be the first to ask my questions. The first one goes to Cynthia. What was that? You see, which period of their treatment journey were these measurements done? Was it 3 months after chemo, after radiotherapy? When exactly were the measurements done to assess the presence or otherwise of the lymphedema? Well, you clearly stated there was no sentinel lymph node biopsy in your presentation, so forget about that one. Do your patients generally have physical therapy after breast surgery and axilla clearance? Is physical therapy incorporated in their management? And I also saw you indicated that patients who received adjuvant chemotherapy, did you assess new adjuvant patients? I mean, was there any difference between those receiving new adjuvant and those? Because now the trend is towards completing chemotherapy before surgery. So if there's an advantage to adjuvant chemotherapy, I think it's something we should be looking at. And my second presenter, you said your patients were patients who have come to seek healthcare. Were they specific to any unit? Like, were they antenatal? Were they more with the obs and gynae session, or it was the general OPD patients you recruited? Okay. Should they answer now, or we want to take some other? Anybody with other? Please, you mentioned your name and your question.
I'm Dorothy, and my question goes to Auntie Cynthia. There is this question I've been meaning to ask, but I haven't gotten the time to ask. And today that I have a lot of experienced doctors here, I would like to
ask because it's really eating me up. It's about Sanya Musi Mujuma. I respect doctors and nurses because of the courageous part of their lives. How can you live your life and every day you are seeing blood? I don't admire you, but I respect you people. This is my problem. This morning when we came, all the presenters that came, they made mention of the fact that after you are done with graduation, the graduation can let you have reoccur. This is where I get sick. What's in many cancer? Me chemotherapy. My bed chemotherapy. What you to me to to ego? Man can't she? Oh yeah. What's in me run minufu? My ba what minufu? Man you sika. What fun free? Man can't she? Oh yeah. Graduation na what's in me na enkili yare no esa de yare for breme. I do not want to understand. And I make question you know it also say managing system. Say any panel would the phone back we say ena ebe mano aye management. Na say would the back who can ebe man ye cure forever. I don't know more understand more confusing. It's to me, it's really confusing. My yari went today. And when you masters baby, me didn't na so after the most sad re-intimate meeting be say cancer platforms be a free so because it scares me. I might tell the truth. It really scares me. Say I deal with I lost my marriage, I lost everything. The only thing I did not leave was my faith in God, that God will heal me. After I have passed through all these stress, after the treatment, now one cancer will recommend the man, no. As another issue for why are you doing this to us?
Good morning. I'm Joyce. Please, my question goes to Cynthia. I don't know if mine is lymphedema or something else. After my surgery, I've been having pain in my arm. Where I did the surgery, I've been having pain. Although I don't use the hand for strenuous activities, but I keep having pain in that arm. No swelling, nothing, but the pain is consistent. So what do I make out of it?
All right, so I'll come back for the second batch of questions and then contributions from some people want to contribute to the ladies' questions, so we'll go to them. But let's Cynthia and lady Stella finish.
All right. So for the first question, regarding when the measurements of the limbs were taken for the assessment, most of our patients that we assessed had had surgery for more than 2 years. Most of the patients we assessed had had surgery more than 2 years. We actually had participants who had had surgery 5 years and more. Okay, the least number we had was 20. We started from 12 months post-surgery, post-therapy, to more than the highest extent we got. And we had some patients who had had surgery more than 5 years involved. Yes, general physical therapy is incorporated in the management of our patients. Actually, on post-op day one, I really can't tell how far I started, so I might not be able to get some of our champions to support us. But for the time I was on the breast unit, on post-op day one, we start physical therapy in helping you to move the arm and all. But for physical therapy to combat lymphedema is when the symptom is noticed, when the swelling is noticed, or you complain of heaviness and you're assessed, and then you are sent to the physical therapist to help teach you the massages with the bandaging and all to prevent the progression of the disease. Okay. And then for adjuvants, looking at whether we did a new adjuvant chemotherapy. I actually didn't put the new adjuvant on my slide so that I had a lot more information. but just brought out the significant ones, those that was associated with the lymphedema. We had patients who had received neoadjuvant chemotherapy, but there was no significant association with lymphedema. That's why I did not show that in the presentation. And as for your question, I need a lot of support. Okay. Please let me hand over to you. I'll do the rest. Okay, let me go to the pain in the arm after the surgery. Yeah, so sometimes with that, looking at the armpit, okay, there are a lot of nerves passing. How long ago was your surgery? 2 years. That's a while. There are nerves. So for the numbness, yes. The numbness, there's actually a particular nerve which before surgery we tell you about. Sometimes we are able to preserve that nerve, other times we are not. But because that nerve is for sensation and not for function, okay, if it happens that we need to get rid of that nerve, we go ahead and do that. Sometimes some people adjust, they don't even notice it anymore with the numbness that they experience. Yes. For the pain, physical therapy can sometimes also help. And sometimes psychological help is able to help you to get over the pain. But if you're able to use the arm as for your daily activities, I think that's good. And you should also be looking out for the swelling, because the lymphedema doesn't have a fixed time to occur. It can happen soon after surgery. It can happen 10 years after surgery. So you have to keep on observing your arm. If you notice anything, you quickly report, because immediately if we start treatment early, it's better than starting it later. Okay. All right. Thank you.
Yes. So in all, I think for me, what she's saying is information. When there's a plan in place and they have enough information, once the patient know that this I may experience this, they are a bit calmer with it and they have support, they're able to go through it. But if there is no enough information, where to go, even if certain things happen, it raises, the distress level becomes high, and that's, I think, affect their quality of life. Okay, so it's, I think it's well taken in. As health professionals, we are all here, clinicians, we need to take into perspective that not after treatment and that is the end. There's a lot of things. Studies have shown that they have a lot of needs across board, right from physical to spiritual. So, and we need to take account of that and make sure that there is some room where they will be able to go, like late onset of some side effect. So we need to make room for that. And that usually survivorship clinic helps in that regard. It's something that is bound to happen, but maybe we give our information in bits. And we also look at our culture to be able to tailor it according to what we can take in. But I think it's well taken. We have a lot of clinicians here, and we are here to see how best we will re-strategize to make life better for both the clinician and also the patient.
Thank you, Starness. She's our Starness. Please, a hand clap for her.
Okay, thank you. Please, my name is Nanama. I'm a radiologist as well, so I'll just and passionate about breast. So let's talk about the radiation again. Dr. Insedus has stepped out. And I'm glad it's coming up because I see we have a lot of champions in the room so that you serve as advocates for us. Now, let's not dwell so much on the radiation bit because let's take radiation as something that when it comes in, your body attempts to repair itself, whatever amount comes in. And Dr. Bedu-Pepra mentioned too, that's physics, that's deep. But just know that whatever radiation you receive, if it is going to do anything to your body at a cellular level, your body is going to attempt to repair itself. And most of the time, it will repair itself. It is when it goes unchecked, that is when we have the process of carcinogenesis and then cancer forms. So that is a long stretch. But she did mention that let's look at the benefit of receiving the radiation to the amount of radiation that you are receiving. The benefit of detecting the cancer process, even before you can feel it, far outweighs how much radiation you are receiving. The background radiation you receive from the sun, from the airplane, from the earth's core, your body will attempt to repair itself. So don't worry so much about it as opposed to what benefit you are getting from the mammography. And I know that this year every Pink October and beyond, it comes up. So now that there are more radiologists involved in this, feel free to come and talk to us and know that the mammography you are getting is more important. Like the benefits of it far, far outweighs whatever risk the radiation will give you. Please, I hope it answers that question.
Maybe I just want to add on a little still on the radiation that you realize there's so many of you and none of you is having the side effect. It's just written because 1 out of so many are getting it. So as you said that your faith never went down, trust in God that even if everybody's going to have it, you'll be the one who will not have it. In Jesus' name, amen.
Essie, kindly.
Yeah, please, with regards to, I mean, what I get from your submission is that we burden you with so many things, and sometimes with each one comes more trouble. Sometimes I tell my patients that once you have the disease and we have to treat, it's like making a journey from, say, Accra to Kumasi. One, you can't make that journey at a go. You won't just close your eyes, open, and then we are in Kumasi. It has to be a process. And two, assuming it was a load I was giving you to carry, and each town on the road is part of that load. If I gave all of that to you at the same time, it would probably crumble you or kill you. So I have to give you that load one at a time. Then maybe when we get to Nsawam and you drop the Nsawam town, then we can carry Nkoko now. And then when we get to Nkoko, you drop that. Because if I put all the towns on your head at the same time, that alone would generate its own stress. And then with regards to the side effects, the same way, if we sit in a car from here to Kumasi, our tie would wear a bit. Or at a point, maybe we'll get a flat tire, we have to change it. See those as like the side effects. Or maybe by the time we even get to Kumasi, our windscreen has cracked. But the ultimate goal is to get to Kumasi. So if we can get to Kumasi and we still have a car, and some small portion of that car has gotten defective, considering that benefit of ultimately we have reached Kumasi and we have achieved that goal versus the cost of getting that was we got a crack on our windscreen or the car paint got scratched and so the car is not sparkling like that again. But ultimately we still have a car that can move and we have reached our destination. So sometimes let's try to process it that way and it helps. And yes, I agree, maybe even when we are giving you the information in pieces, sometimes we are not able to give all of it. Please, when you have questions, please ask us as well. At times, I tell my patients, write it down. You see, by the time you enter the consulting, it's like you've forgotten everything. So I ask my patients, keep a small book. Even if you can't write it yourself, maybe your child or somebody is able to write. When something comes to your mind, let them write it in that book. That's your, should I say, your journal or whatever for the whole journey. So that when you come to the clinic, then now you open those books and say, 2 weeks ago, this thing came to my mind. I want us to talk about it. 3 weeks ago, this thing came to my mind. It helps. We won't solve everything one day, but one day at a time as a strong team would always win. Thank you.
Thank you very much. Essie, Essinam. Do you live in Kumasi? Yes, I do. Okay. Please, we'll take the last batch of questions. I'll come to you. You want to add something to us? Briefly, please.
Thank you. Thank you for giving me the opportunity. Okay, I share in the pain of the ladies. I call them precious ladies because of what they go through on daily basis. I stay with them and I know how it is. So when you go to our office, Safe Haven, you see an inscription. She is clothed with beauty, strength, and not afraid of what the future brings. This is our hallmark. You know, if you want to live for yourself and what you are going through, we will be very frustrated. So we have to take it one at a time and then see what God can do for us. The doctors are doing their best. They are trying so hard for us to get well. But the major decision depends on us. That I want to live for myself and not afraid of what the future brings. Mama Janet will always tell you, I treat every day special. And when I get the list of time, I party. You can just be going and the car will hit you, you are gone. Some people started with us, they are not here with us. So, my ladies, I want you to be strong. The way you have beautified yourself today is an inscription that we are living for tomorrow. Nobody is dying soon, and we love you all.
Hello, good morning. Dr. Naomi, please, I would like to say that you have to do more to let the patients know about their treatment, because most of the cancer patients that I come across with, whenever I ask them what stage is your breast cancer, chemotherapy, how many cycles are you taking? Radiation, I've come across more than 20 people that I normally encourage them that they should go through the treatment. But they will tell you that they don't know the stage of their cancer. They even don't know whether it's invasive ductal carcinoma or triple miniminachole. So triple negative. So please, hair 2, hair 3, hair 1. So please, whenever the patients come to you, when you diagnose them, please, I beg you, let them know the stage of the cancer and then the chemotherapy that they will be taking and then the radiation and everything. Thank you that you have taken it in. Ni here yakashin nye ba chuhe ni nye ba hawo. Ni Kristo ba jonye nye nuchumo hu ba ya hiye anye. Amen.
Yeah, please, the sessions, please, are they related to the two presentations? All right.
All right. So mine also goes to, in fact, I'm not good with names. The doctor that presented about lymphedema. Okay. So this is a suggestion I would like to make. You know, when we are getting our treatments, I would like to suggest that we are referred, na my referral note to go and see a physical therapist. That one, when I am going chest out. I know, say, doctor na suma me say, minko physical therapist. But it shouldn't be that we will be doing knee-jerk, you can't say at the end saying, action. So if I don't come and complain, then I am not told where to go. Or sometimes you complain and they ask, what dietitian? Me, I don't know if I should go and see a dietitian. What physical therapist? I don't know. And then general physicians. Apparently, we are supposed to go and see a general physician. I did not know until my BP started spiking when I had to go do surgery. I think going to lose both breasts and thinking about all those things. Yes. So my BP started spiking And then they keep asking, do you have BP? I say no. Everyone was asking me, do you have BP? So then after everything, I had to go see a general physician. So my suggestion is that when we come for treatment, refer us so that we know exactly where to go. And then please, some of us were complaining that brofone dosuntoto. Yeah, pamucho. And yes, our doctors do very well when they meet us on the time with survivors. On the monthly time with survivors, we do. They mix the brofo with chi. And the pa muka brofo na mudi chi ni kanwa. Yet see us ye no ye account for ye nya brofo into yes remoa. Money ye kasabo de botanical names to muntimin can chi moi. Said the mube to me a can be a ye bet ye damose.
Comfort Osu. This is my 17th year of survival. One thing I noticed. I'm talking about the numbness. For 17 years, I still experience it. And one thing I noticed that I want clarification is that I realize anytime I go to the kitchen, sometimes it becomes, severe, or so to speak, or it becomes harder. Then I try to find out why it was so. Then I got to know that anytime I go to the kitchen and the microwave was on, and I'm a bit close to it, I feel the sensation through the side until it's off. Oh, please, why is it so?
I don't know what to say. Please, which side did you have the surgery on? The right side. When you started your question, I was actually thinking that when you go to the kitchen, because you use the hand more, okay, use it to cut things, you use it to lift up things, you are stirring food and all that, so you might have the heaviness on that side a bit more. But chipping, exactly, because it's the same hand. Most of the people who have the surgery on the dominant side, like this, you are right-handed and your surgery is on the right, or you are left-handed, your surgery is on the left, you might experience more discomfort because that's the hand you use to do a lot of things. Exactly. But chipping in the microwave now, this is the first time I'm hearing it. Maybe my other colleagues can.
No, it's something interesting we should all look at.
I think maybe we have to look
it's
into
a
it.
steady
And
topic,
then, yes,
and we are going to look at
see
it.
a lot more. Yes, please. All right. Thank you.
Stella, you've not, about.
So
my
with the
question.
participants, we didn't have, we had them from the OPD basis.
All across.
Exactly. When you get to the hospital within the research time and you are 18 years and above and you're a woman, we do that.
All right. Thank you, everybody, for this first session. My name is Professor Ishmael. I'm also with the breast surgery unit. I must admit that we need to interact a bit more. Forgive us. Sometimes the numbers and the stress and all that. Forgive us. We've learned something and we're going to improve. Please, let's put our hands together and welcome Naomi to head the second session. Thank you.
Thank you. I think Bande just sent some slides, and I think he had a lot of abstract, so we didn't know which one it is. But this one is just a brief. It was talking about climate changes affecting palliative care patient. And there has been some studies that have shown that we are having a lot of climate changes, and this is affecting a lot of cancer patients in terms of these heat waves and flooding. So they did a study at the Whole Teaching Hospital looking at palliative care patient, and there was some association because if I could read one or two for the would I say the discussion. They had one of the themes was extreme heat, and a patient was saying the heat is too much these days. Sometimes I cannot even sleep at night because of it. I stay awake, sweating until morning, and by the time I have to go for my review at the hospital, I'm already exhausted. And the nurses ask me how I'm feeling. But the truth is that the heat alone makes me weak. So, and later on, there were some disruption of treatment. And sometimes because of the way they are feeling, let's say the way the weather is so cold, and it usually gets to them. And when they are flooding, they are not able to maybe board a car and come to maybe therapy. Let's say you are having radiotherapy every day, and there is that flood. There's also disruption. So all that were put together, and sometimes symptom or exhaustion also comes in. And finally, so they found out that there is some perceived influence of climate related environmental conditions on the care of patients. And this is able to demonstrate causal effect, and the findings illustrate how participants interpret extreme heat, flooding, and unreliable electricity factors. When the electricity, there is fluctuation, that also affects the delivery of radiotherapy, and that also distracts the treatments. And so all these things cause some complications in symptom management and distraction of healthcare access and affect their daily life. So in conclusion, we're saying that studies found that climate-related environmental stresses, including extreme heat, flooding, and unreliable electricity, were perceived to adversely influence the palliative care continuum and the quality of life of women with breast cancer. So we need to strengthen have a climate resilient palliative care system, which should expand from community-based services and should integrate climate adaptation into oncology nursing practice and policy. And this will be essential to enhance the continuity of care and improve patient outcomes, right? So we're moving to our next session, and this section brings together researches that is exploring different dimensions of breast cancer care, and importantly, help us to understand where patients may still be falling through the cracks. And for the first presentation will come from Dr. Bedupipra, who will be presenting on breast cancer navigation system at Confanotion Teaching Hospital. Yeah. You would like, okay.
Good morning, ladies and gentlemen. Yeah, my name is Othniel Domfe. You can hear. Hello. So, hello. Yeah, my name is Othniel Domfe, and I'm the project manager for this study. I'll be presenting on behalf of Dr. Augustina Bedupipra, who is a PI and the HOD of Radiology Directorate, Confanoche. So, our study, Breast Cancer Navigation System at Confanoche, it features, the real-life experiences of 306 participants, including 208 quantitative analysis from patients and 25 qualitative analysis from clinicians. So the goal of the study is very simple. We want to understand where the patients get lost throughout the care study. That is why we're doing this. Yeah. So for our presentation, this will be the course outline. It's in 7 concise segments. To begin with, according to the American Cancer Society 2023, every year about 2 million women are diagnosed of breast cancer. And in Ghana, it is the number one cause of cancer-related morbidity among women. Now, for our site, that is Confanochi, we identified some gap patterns, that is late state diagnosis, fragmented care, which is as a result of these 5 key barriers: the geographic isolation. And as we all know, looking at the location of Confanochi, it is difficult to connect the northern and the southern regions. And also the financial constraint, the cultural stigma, which I do believe we will all agree with me. We know the pressure on women in our Ghanaian society, from marriage to education. I mean, it cuts across. So you can only imagine what they go through here. And also the referral loopholes. And last, there is no utilization of mobile health. For our study, these are the objectives that I stated earlier. We want to understand where they get lost, the delays. We want to assess the navigation system present. We want to develop a new one for them if necessary. And in this case, it is necessary. We want to explore the role of technology. And lastly, we want to measure the metrics. For our study, we use the cross-sectional study and also qualitative analysis. For the quantitative, we analyze with Python and Spearman correlation of analysis. And the qualitative, we use Braun and Clark 6-phase framework. Yeah. So to begin with the quantitative, due to the time, I will just press on the most significant ones. Half of our patients, they got to learn of their breast cancer through friends and families, which is a clear indication that we need to up our game when it comes to awareness and education. And 79.1% of the patients experience immediate psychological distress, which is very bad. As you can see from the table, fear and anxiety coming the highest at 30% and acceptance coming 21%. The same with the friends and families, receiving their information from friends and families at 50%, doctors and nurses at 44%. So with the treatment types, 5 treatments were recommended to our patients, with chemo being the highest and hormone therapy being the lowest. And what we realized is 24.5% of our patients, they had to wait 3 months or more after their diagnosis before treatment, which is, I mean, as clinicians, you all know it is a risk to the their survivorship. And even according to WHO, in their Global Cancer Initiative, that breast cancer evaluation should not exceed more than 60 days. So they're waiting for more than 3 months. It's a serious situation we need to. Throughout this journey, there was no utilization of technology. So for their delays, we realized it came in 3 ways. The majority was due to financial constraints, coming at 58%, medical complications at 31.9%, and system delays at 8.8%. And 87.6% of the patients, they all faced, they reported negative psychological impact, which I will explain in the next one. So this part of our study is what we call the paradox of our study, because although, as you can see here, there's an indication of clarity here, yet our patients faced what we call psychological distress, because sometimes the information can come to them unfiltered, can come to them unhinged. So there needs to be a bit of psychological cushioning over there. That explains the negative psychological impact over there. And the last bit of quantitative analysis is the correlation. So as I stated earlier, the clearer the information, the more psychological distress they experienced. And also age, it was regardless of, psychological distress is regardless of your age. Whether you are old, whether you are young, you can still experience psychological distress. And also, we realize that education has a positive marginal correlation to the clarity. That is for the quantitative. So moving on to the qualitative, it's a bit of an emphasis to the quantitative. With the first theme, that is financial and structural barriers, all the respondents agreeing that that is the reason the patients had to halt mid-course, which is something we need to take control of. And also the second theme, communication technically adequate, psychologically insufficient. This is because we realized there was no verbal framework at Confanoche, something we need to take a look at. It's all dependent on the clinician's expertise and experience. So how the information comes to the patient, it depends on the clinician. And also the psychological support throughout the treatment, it is absent. From the beginning to post-treatment, there is no psychological treatment for, and even one oncologist stating that patients receive a diagnosis and are sent home to wait. The first 2 to 4 weeks are where the system fails most visibly. So this is something we need to take a look at. And last, the utilization of mobile health. There is no mobile health for our patients. Some of our respondents argued that this is due to the cost of data. When technology is introduced, not everyone can afford to get it. And also others argue that the literacy varies, So when we triangulate the qualitative voices with the quantitative numbers, these are our 5 key recommendations, which I will explain here. So it comes into our proposal. What do I call it? The basis of our research. So this is our proposed navigation framework. So it spans a 5-phase continuum, right? Starting from community entry, diagnosis, treatment, active support, and survivorship, which is dependent on these 4 key core pillars down here. The navigator coordination, we need a nurse or a community health worker-led navigator for each patient, and also psychological support right from day one, from pre-treatment, prepping them to post-treatment, and also a financial navigation system. We need to give them access to CAT cancer treatment fund, which we hope we can initiate, right? And also the last is the mobile health is something very important because it's 2026. We are in a modern world. AI is all over. This low technology, SMS reminders, chatbots, and everything. We need to utilize it. So the aim of this proposal is we want to reduce the financial delays from 58.8% to less than 30%, and also psychological impact to less than 60%. And we want to increase the use of mobile health up to more than 60%. And lastly, which is the most important, the delays, we need to reduce it to a relatively low number, even less than what we provided here. That is the 10%. And also enhance on our communication clarity. So to conclude, overall, Confanoche is known for, it has a remarkable clinical care, no doubt. Yet we lack in these 3 key, we have these 3 key deficits. That is the financial barrier crisis, the psychological impact, and no mobile health. This is something we need to address, right? Because the WHO calls on us to reduce the mortality rate by 2.5% every year. And I know this cannot be achieved through only chemo and surgery. We need to support the women. We need to guide them throughout the journey. So to end it all, I will say that the battle of breast cancer, bridging the gap of breast cancer is not just an academic ambition, but also it's a moral obligation and a clinical obligation as well to our mothers, to our sisters, to our wives, to all the women in this country. Right. Thank you very much, ladies and gentlemen. So.
Oh, thank you. Hello. Yes, any comments? Okay. Okay, yeah.
Thank you very much. My name is Gifty. So, at the latter part of your presentation, you came out with, if I may call it, a framework or a recommendation of, or your objective, what you seek to do. One of them is the financial burdens that the patients go through, and you seek to reduce it from 58.8 to 30%. Do you have a proposed plan on how to achieve this from what you have presented?
Thank you very much. So there was a review tariff that I was part of. So NHIA yesterday they presented that they are trying to put some of the things on the NHIA. And we're also thinking that as institutions, we can also have a fund to support these cases to reduce their financial burden.
Thank you very much. I'm happy the issue of navigation is coming up this time around. Last year, I was here, I did a presentation on what I have developed as a comprehensive, context-specific, culturally sensitive navigation program for cancer care in Ghana. And then I remember what Dr. Mensah presented last year in terms of the cases that were identified at Konfanochi and the cases that actually came for care. We realized that we were losing more than 50%. So that day we said that, okay, why don't we now adopt the tool and then use it across? Because currently the navigation program we are using in Ghana is not stemming across the continuum of care. So the navigation, we should be able to detect the cases early. So we have what you call the screening navigation, the community entry. We should have the screening. Then we come to diagnosis, we come to treatment, we come to survivorship. And because we identify cases late, yesterday we had 60 to 80%, we should have end-of-life navigation. Now we have these two. Unfortunately in Ghana, because the government hasn't taken it up, or maybe institutions haven't taken it up, we see, let me say, some scattered navigation programs in our teaching hospitals. Anytime we meet here, we are told that we should identify cases early. Who should identify the cases in the village? How do we do it? It is because whoever is leading navigation also has an interest. And for that matter, I wouldn't go into the communities and detect the cases early. I am thinking that it's about time. I'm happy. I don't think there is a need for us to develop a navigation program. I did my PhD for 4 years. I used 2 years. I used ethnographic study. I visited and stayed in the institutions to see what was happening. And I took this data. I did a scoping review of existing navigation programs globally to design that particular program. So I am thinking that it is fresh for us. And this one, it also incorporates technology and also the family members, because if you leave the family members out, we will not be able to achieve it. So it is ready. We can partner with Broad Society. Let us adopt it and then we can use it. I remember I told Prof. Shea about it yesterday. He was like, oh yes, I've heard about you from, what's the name? I've forgotten her name. Emilia, yes, Sister Emilia. So please, there is. So you don't have to. Yes, please. Yes, so that we'll use it. Thank you very much. Most grateful.
Thank you. Thank you, Dr. Dusu. Any other please? I believe that a lot of things were going to our minds when the data was being shared. So with what Dr. Maria did, and I think we all are set to it that navigation needs to be properly incorporated into our system for us to have a better patient outcome. It's not just treatment, a whole lot of things go into play. So we all here, I believe it's multidisciplinary, both the patient, right? And I hope a policy person is here. Right. Okay. Yeah.
Hello, my name is Janet Adade. I just want to add my voice to this about the screening process. When you go to the community after screening, what do you do? What do you tell the patient? You have identified a lump in a woman's breast. What do you do? What we tell them is go to Kulibu, go to Konfanochi, go to Bisiansi Hospital. So, for example, they go to Kolebu. Kolebu is big. Where do the person go? Even to ask somebody that, where is surgical or this thing, the nurse or whatever is, they will just point, this is surgical. So you go to surgical. Where do you go? There's nowhere. You are just there. Nobody has time for you to tell you to do this or that. So the person just returned to wherever he came from, she came from, or he or she came from. So I think it's proper we take note of those we identified, with breast lumps and so on and so forth. Tell them, direct them where to go, follow up. You see, so you go to you just have names, their numbers and so on and so forth, and call them to go to oncology or surgical or wherever the person is supposed to go, so that you can't just leave them just hanging anyway, so that we can at least catch them early. Other than that, they will go to some places where they will be seen early. Because I sat in a bus that they will tell you that they have medicine that is 5 cedis. You just put it on the breast, you will be okay. Why do I have to go to Kolebu where there's nobody to lead me, tell me whatever to do? So I buy the medicine and put it on it, and then I'm okay. I think I will feel I'm okay, but I'll be okay. So I think there should be something, communication, how to lead them to wherever they are supposed to go. Thank you.
Yeah, thank you very much, Auntie Jane. I think there has been I think Japaico is leading a project where they are trying to doing a phase where they're trying to get right from the community and then to the hospital, trying to do navigation right from community to the hospital. If you look at our standard treatment guidelines, it is also specifically in there and trying to come out with exactly what is supposed to be done. And then they are selected. We're trying to do a decentralization. But a huma and a guide, let's say, be wo Ministry of Health, you per se, they are selected places, you per se, cancer treatment ni be started free. Honomo in a senior say screening a be as a circle. Na senior be phone yira because senior antigen kayen so bibia o se Kolebu okojina Kolebu a uka so bimbe sa wo Kolebu kra na ne yam ehyehye no it's too big me am wo hon so bika say ya refer me to Kolebu kra na ye adeswa amame so senior can it's a collective agreement and your bonyame mpa say this year no they are setting out say sa niama nyina ye de betutu akwemu senior be ya ye bibi wo community obi abehu say as I say or de ko hanom nima nimdia ebu wo ha ne enye hwe no de to but say right from the source nipa no wo ho no onim idea as I say oya ohun bibia obehu baby or de be den ebeko ina senior sister can say as I say onanti all the way people have to come all the way to those centers but yeah bonyame pai say neom dey atutu akwem there will be some form of decentralization because people have been trained ebimu at least nurse specialists were even right in the district hospitals near there now some form of treatment be decentralized na aboa your patients mbajo mekaniye inti we will move it to the next presenter. Yes. Oh, sorry. To the midwife. Oh. No, say district hodom no mo was surgeon near there. You know, spelling it out. Na abuama obi ehu baby as a circle. Why? But the next. So I think we are behind time. So the rest of the presenters will finish all their presentation. Then we'll have 1 or 2 questions. Right. Thank you very much. Okay. So, so please, do we have Mr. Kingsley Bosompem? Okay. Next presentation. Followed by Dr. Agbeko.
All right, good afternoon, everyone. All right, so we are closing the breast cancer surgical care gap. So we want to look at the first 20 cases from a new oncoplastic breast surgery program at Confanoche Teaching Hospital. Can we, next slide. So these are my authors, profs here. So in many African settings, most women with breast cancer present with advanced disease. And I think that reflecting major gaps in timely diagnosis and access to acceptable high quality surgical care. And breast cancer, of course, presents very late. And this late presentation is driven in part by fear of mastectomy. Because many people are afraid of mastectomy, they don't even come, or they come very late. So when we talk about oncoplastic breast surgery, we combine oncologic resection with plastic techniques to achieve both tumor control and improve cosmesis. And this may help address these barriers to early presentation and acceptance of surgery. Additionally, oncoplastic breast surgery offers reconstruction techniques for large chest wall defects in locally advanced breast cancer. So we report our early experience. So the objective is to evaluate the feasibility, safety, early oncologic and aesthetic outcomes of the first 20 oncoplastic breast surgeries performed within a newly post-fellowship program in Ghana. The Ghana College started this program this year. So it was a retrospective review of consecutive patients undergoing oncoplastic breast surgery and a certain plastic and reconstructive division of Confanoche Teaching Hospital and the breast care clinic from January 2026 to July 2026. So 15 of the patients underwent oncoplastic breast conservation surgeries using either volume displacement or replacement techniques. And then 5 patients with large chest wall defects after mastectomy were reconstructed with LD and then thoracoabdominal flaps. Latissimus dorsal flap is LD. So we look at their demographics, immunohistochemistries, operative details, aesthetic outcome, post-operative outcome, and so on. So these were the results. We look at their ages. Is it right or left breast, location of the tumor, virtually all the quadrants, then the stage, mainly stage 1, stage 2, the immunos, and the YT is the tumor size after chemotherapy. Then the specific technique used, the margins, and then lymph node dissection. Then the duration of the surgery it takes time. And this is those with the locally advanced breast cancer, the immunos and the sizes. So this is a result of the locally advanced breast cancer, 35, 15, 20, and all that. So volume displacement techniques, therapeutic mammoplasty were used in 14 out of 15 cases. One had volume replacement technique with latissimus dorsal flap. 10 out of the 15 cases had contralateral breast reductions. Now, when you reduce one particular breast, we want to match the symmetry. So we operate on the other breast. Clear margins were achieved in all the 15 cases. No re-excision. And axillary lymph node dissection were performed in 13 out of the 15 cases and were considered to be adequate. 2 patients had low, out of the 13, 2 of them had low axillary sampling. And post-op complication occurred in 3 patients, mainly seroma, delayed wound healing. However, there was no major complication requiring return to theater. With the chest wall reconstruction for locally advanced breast cancer, All the 5 defects were successfully covered. 4 of them had minor wound complications, and adjuvant treatment was not significantly delayed. So with the aesthetic outcome, we use a simple 4-point surgical scale. We ask the patients, are you satisfied with the outcome? They just respond, whether they are okay with it or not. So these early results suggest that even in a low resource constraint setting, oncoplastic technique can provide not only oncologically sound surgery, but also acceptable aesthetic outcome that matter to the patient. So this was one of the cases we did. This lady had a tumor about 6 by 7 centimeters left breast. These are pre-op markings for therapeutic mammoplasty. This is an immediate post-op. So we've converted the breast to that of a 16-year-old, and she had a surgery. This tumor was centrally located on the left breast. So we had a central mastectomy using therapeutic mammoplasty, 2 weeks post-op. She was very, very happy after the surgery. We have what we call the extreme oncoplasty, where we use advanced oncoplastic techniques to salvage tumors that are quite advanced. So this lady had a 6 by 4 centimeter tumor in the upper inner quadrant of the right breast. She's had a new adjuvant chemotherapy, but response was very, very poor. But the tumor biology was very good. So we did what we call a dual pedicle therapeutic mammoplasty. So after the quadrantectomy, a double flap carried the nipple areolar complex, and then the terms are we were able to reshape the breast. Okay. So this was the immediate outcome. So the tumor was at a pointer, I think it's clear, and she's so excited. I mean, with a very big tumor. Now, when it comes to chest wall reconstruction, so a young lady, 29-year-old, with a malignant phyllodes tumor, with the involvement of the pet major and part of the pet minor, we were able to completely excise, took out the whole pet major and part of the pet minor, and we did a reconstruction using the thoracoabdominal flap. This was a laterally based one, together with an LD, latissimus dorsi. We took part of the muscle from the back. We were still not able to cover the defect, so we added a skin graft. 8 weeks post-op, she's back to. And then this elderly woman had, I think, about 27 by 20 tumor of the left breast after neoadjuvant chemotherapy. Simple mastectomy will not be able to cover this defect. So we used a thoracoabdominal flap to cover the defect. So these are early results. We just started in January 2026. And so I want to tell the women that if you present very early, we'll give you a very nice breast. Thank you very much. Well, this is a new program. Maybe after it's a new program, they didn't pay anything. Maybe I have to see my trainer for the very, very affordable. So they just I'll make my number available. Yeah. This one. Okay, this one. Yes, so next time. Yeah. So I think when they put it.
Good afternoon, everyone, and thank you for the opportunity to speak to you about our work in Kumasi, looking at patients' journey from when there's a suspicion of breast cancer to when they eventually get a diagnosis. It's just from when there's a suspicion to when they get a diagnosis. This study is sponsored by CCAN, City Cancer Challenge, is trying to turn Kumasi City into a comprehensive cancer navigation, everything for at least breast, cervical, and prostate for now. Hopefully, everybody will benefit from it. But in fact, I won't spend time on these slides. We all know that that journey starts from a woman finds something in the breast, she thinks about it, she goes to see someone in a hospital, they have to process that, referrals, all that. But the expectation is that from when there's a suspicion to when we have established a diagnosis, ready to treat you, that should be within 60 days. If you are spending longer than that time to be able to get to that diagnosis, then there's a problem and there must be at least interventions to mitigate that. And so what we wanted to do was evaluate within this greater Kumasi area, knowing there are centers that should be able to provide these diagnostic services to patients, how patients are actually going through the system to achieve that diagnosis. So broadly, as a whole study, we had these 6 objectives, ultimately arriving at we should be able to make recommendations within our navigation system. I'm looking at her because I know she's passionate about it, to make sure that every woman reaches this target and even at better times. The study is still ongoing, and so most of what I'm presenting to you today is around our second objective with regards to the timelines that we have found so far. So it's purely observational, and really if a woman came to any of the recruiting sites, once 18 years and above with symptoms in her breast that's suspicious, once we consent you, that is it. That you are I like to put it lay as you want us to spy on you, kind of, because we're never going to call you again to find out have you come back or not. But we check the clinic records all the time to see who has returned, because we felt maybe if we are calling you and all those things, that is what might pressurize someone to take an action. But we wanted to really observe what is naturally occurring. We recruited women from March to July, and we are still doing our spy follow-up and giving ourselves up to 3 months from the last date that the last woman was recruited to see when they would come back. There were 271 women recruited over the period. Most of them were in Komfanochi Teaching Hospital. Our other recruitment sites were KNUST Hospital and then Hope Exchange Medical Center. And these centers were chosen based on initial assessments that had been done by CCAN over the past 2 years or more about hospitals in Kumasi where women are likely to go with symptoms suggestive of breast cancer. We know that some people may have ended up in a private space or something, but those are really small numbers that for the feasibility of the study was not going to be. The mean age of our women was just about 42. And up to 170 of them would have visited another facility before arriving at these places. But the average number was really, we got 1.4 from a calculation, which means essentially maybe most people would not, and it's here, 101, would not have gone anywhere else besides they found something in their breast and they came to one of these 3 hospitals. Komfanochi has a breast cancer, a breast clinic, which is separate from, it's a building separate from the rest of the hospital. And you don't need, it's a walk-in space, Monday to Friday. So far as it's not a public holiday, you could be walking through the hospital, going to another part of town. And if you entered that space and told the nurses you want them to examine your breast, they will do that. And so probably that's, plus if they had been to any other facility and they were being referred, then they will come to us directly. And that's probably why most of the recruitments ended up being from there. What this graph is about is, so you see, once we recruit you, this is your initial presentation to either of these hospitals. We just check all these clinic records every clinic day. In the Komfanochi Breast Clinic, for example, that's Monday to Friday. We go look at all the patients who have checked in because there's a record and then find out. Particularly And like I said, follow-up hasn't completed. So where there are missingness, we are anticipating or hoping that they would come to fill the gap. But if you look at just the mammogram section, so for each color bars represent one diagnostic event. So you look at the mammogram section, for example, and then so far we know that 133 women had mammograms requested, but only 120 had come back with the results. So technically, at this point, they've probably been lost, unless by October they show up with those results. Same way, if they had a biopsy requested, 185 had biopsies requested, but 140 have so far brought their results back. So that tells us even within that level again, someone falls somewhere along the line. And we've tried to track women all the way to when they would have had staging investigation. That's at least you've had a chest CT or a breast, an abdominal ultrasound to check whether your disease is metastatic or not. Now we looked at the wait times. And the wait times, we were measuring when the request was given to you to when the investigation was actually performed, when the investigation was performed to when it was actually reported, and when it was reported to when it was presented to a doctor. So that's what these colors represent. And I've just picked out these few. If you take mammograms, right, so this is 0 to 100 for number of days. You realize maybe most of the people are doing it within maybe up to 20 days or something. But if you take mammogram, biopsy by ultrasound, chest CT scan, IHC, what is concerning are these other dots that fall in these large number of days. Because we say we are closing the gap for every woman. So personally, I think even if there are 50 women and 40 make it within the days, the 10 that don't make it is equally concerning because those are also 10 special women that should be. So zooming in, for those ones that I picked out, you'd realize we're probably having issues around biopsies and tissue, and that is what actually establishes the diagnosis for us to be able to move forward, right? So from when the blue is for when the request was made and when the test was performed, and then when the test was performed to when they actually brought the report back to the doctor. And these are almost a month to get immunohistochemistry if you had to, or even the biopsy report. If you had biopsy by ultrasound, probably took some number of days to get the test done after it had been requested. For biopsy by palpation, most of the time, maybe the same day, because in our breast clinic, you would get biopsy that same day so far as you were ready for it. Moving on, same for cost. We looked at what they actually pay for the test and how much does it cost them to pick transportation to where they are going, if they had to eat, if they came with someone else. Again, direct costs around things like CT scan, if they had to do biopsy by ultrasound, were high. Biopsy by palpation, we are interpreting this with care because in Confanoche, there's a program going on, a study that covers a lot of the cost that goes into it. But then looking at the broad data, people would probably pay, if they were not doing it in cut, up to 1,200 to even have biopsy by palpation. So begin to see how much is going into it. So far, we had completed follow-up for 171 women, 70% of whom had malignant disease. And if they had been somewhere else before they got to the hospital they were recruited from, the average time from that we're calling the first diagnostic encounter, which is when they had a clinical breast exam, and to when it was established that, look, you have malignant disease and all, that's about 69 days. Of course, this includes all those who really fall into, some were coming to us having had a first clinical encounter maybe more than a year or something ago. And then if they had visited a prior facility, this is about the mean number of days. But going back to making that 60 days gap, we see that up to about 51 out of 85 women who have, and this is just for the malignant cohort, the cancer cohort, because that's for those with non-cancer things. So they were probably not going to go into a biopsy, or if they just had a biopsy, then things just concluded there. I mean, 60%, yes, that's fine. What I've tried to do is not compared to what is in literature. Because even if in other countries they are doing 50% and we are doing 60%, yes, that's better. But 40% is also a big number, right? So if we pick every 10 women and 4 of them are not making that, that's as much important as even if it was one woman. And I think sometimes when we do these conversations, we can't hide behind the statistic, because whoever falls on that minority side is equally important. So yes, we have, so far we think that a significant proportion are not meeting that timeline, and the turnaround time for reporting pathological things is probably an area that needs looking at. Like I said, the study is still going on, and now we are going to move on to qualitative interviews to try to interview
Hi, good afternoon to you all. I think it's looking for us. As they could not be palpated on physical examination. And we can manage this by performing conserving surgeries. With the expansion of screening programs across the sub-Saharan Africa, we can do this by introducing or continuously performing the wire-guided localization technique. So our objective for this study was to report the initial experience of wire-guided localization of non-palpable breast lesions. And this was done at the Premier Teaching Hospital in Ghana. We evaluated the Barrett's category of the lesions and then also assessed the characteristics of these masses or lesions. So we conducted a retrospective study over a 4-year period, and we were able to recruit 45 participants into our study. We were able to analyze the clinical, the radiological characteristics of the lesions, histopathological data of all these 45 participants in the study. And these patients or participants underwent the image-guided wire localization of the non-palpable breast lesions. And this was done prior or before they undergoing the operation or surgery. Now, we used the descriptive characteristics to summarize the data, and we reported it as the median and percentages of what we got. So to perform the procedure, the area was anesthetized, and then we put in or we insert a Q-type disposable localization wire device. And this is to help the surgeon excise or resect the lesion or the mass. The localization was intralesional, and this was performed in the radiology department without the surgeon being present. So this is a cartoon image showing us how ultrasound guided procedures are performed. So we used a loose sterile dressing, which is placed over the wire, which will be inserted into the lesion. Oh, don't be afraid. And then we tape it down. Then the size and then the location of the lesion is noted down. We write it down. Okay. Sorry. Then we also are able to, so on this form, you can see that we have a pictorial drawing of the lesion in the breast, and then we are able to tell we mark the distance from the skin, where A is the skin, to the lesion. And then we also track the distance from the distance along the wire, that is from B to the lesion. This information is very important to the surgeons. So each patient was taken to the theater on the same day after the localization is done, and the lesion is excised under general anesthesia. So out of the 45 participants, we had 45 specimens who had undergone, these patients had undergone the wire localization, and the median age at presentation was 50 years. The indications included 13.3% of these patients had undergone neoadjuvant chemotherapy, and we also had 40% who were chemotherapy naive. That means they had never undergone chemotherapy before the wire-guided localization was performed. The median size of the lesions that were resected was about 13 millimeters. So you can imagine how tiny it was. Excision was associated with clear margins in most of the cases. We had up to 53% of these cases that were malignant, and most of them happened to be invasive ductal carcinoma, no specific type. So, like I mentioned, the median age was 50 years old. For those who had malignant lesions, the median age for that group was 51. Clinically non-palpable breast lesions, most of the lesions were non-palpable. We couldn't palpate them when we did the physical examination. But then on ultrasound examination, we could see them. Like I mentioned, 13 millimeters is quite tiny for us to be able to feel with our bare hands. 24 of the cases were malignant, and that formed the 13.3%. And they were larger than clinically palpable tumors, and these were within T3 and then T4 stages. The rest of the cases were 46.7%, and they were radiologically indeterminate. So for the histological yield, we had 53.3% being malignant, 4.1% demonstrated no significant residual tumor following neoadjuvant chemotherapy. This study was done to evaluate the operationalization of wire-guided localization in Ghana. And this was to facilitate breast conserving therapy in our country, or in low middle income countries just like Ghana. We don't need to take out the whole breast if the lesion is very small. That is the intent. So of much importance was the size of the lesion, like I've been mentioning. Similar sizes were also reported by Dimitrowska, who used hook wire localization on ultrasound and mammography to localize lesions, and their lesions were between 5 to 20 millimeters. Evidence of successful surgical excision with wire-guided localization includes the degree of completeness of resection without a requirement for re-excision. That you go in, we are hoping that you go in once and then don't have to go back again. And the acceptability of oncoplastic outcome as well.
So the overall experience was that with guided localization over the past 4 years, we had a positive outcome, and all lesions except one demonstrated sufficiently clear margins. So out of the 13.3% malignant lesions that were resected, most of them had clear margins except one. Okay, so it means that the guided localization technique is very good to use. The study also showed that we compared this to other studies, and this showed that cryo-assisted localization had the highest margin positivity rate, followed by guided localization, and we had intraoperative ultrasound localization being the lowest. Our limitations included the small sample size and then the fact that we had to conduct a retrospective study. We proposed that a prospective study be performed or be carried out, and then also do this in a wider with a wider sample size. So in conclusion, our study followed guided localization, and this was associated with clear margins in almost all our cases. About half of our lesions were malignant. This technique enhances the completeness of excision of small lesions, non-palpable small lesions, and breast conserving surgery. Guided localization is recommended as an effective tool for localizing non-palpable breast lesions, making breast conserving therapies a reality in low middle income countries like Ghana. These are my references. Thank you.
Thank you very much. Can we have all the presenters, maybe a quick one? So 2 minutes. So 2 questions. We had right from navigation. I think we talked about navigation. We also have Dr. Bosomchin telling about the reconstruction availability, and then we've talked about Dr. Agbeku also talking about in terms of following up of patient right from diagnosis to treatment, and also we've had another enhancement from the radiology department in terms of wire, yeah, so that will help conservation, right? So please, yeah, okay.
So my question about the wire localization, the people that did not have a response, as in the people who were fresh, you know, there was a percentage that had reduced from palpable to non-palpable after neoadjuvant chemotherapy, but the rest did not have chemotherapy. So how was those non-palpable masses detected?
So this was done through the screening programs that we have across the country. I think during Pink October, or patients just walking in to get their breast examined, and then from physical examination, they move on to get some imaging done. So these were how those ones were detected. If they were presenting with symptoms, you palpate, you can't find anything, you send them for imaging. Sometimes you are able to pick these non-palpable lesions.
My question is about this to the study from Kumasi. I saw something about mammogram guided biopsy. Is that correct? One of your slides, when there was hand directed, image directed, I saw mammogram.
I think it's been captured. It was probably a CT guided biopsy. There's a facility in Kumasi that does that for when we have these, non-palpable lesions, and then they need image-guided biopsy, and the ultrasound too, the radiologist is still not able to see anything. So yeah, there was just one patient that had that.
Okay, I think we are running behind time, so thank you very much, all presenters. As we continue to think about what can we do as we are bridging the gap, and we still continue to think about it. What as clinicians, what can we do to be able to carry everyone along, and also our support group, the patient. So on that note, I will hand over to Dr. Godfrey J to continue the session. Thank you.
So I know most of you are tired, but we are going to do it in a short time. So this session, which is the section 3, is very important. It's talking about importance of family in the management of patient with cancer. It also talks about spirituality, and it talks about ethical issues as well. We will have 3 presentations. 2 of the presentations will be done by Dr. Mary, and is Madam Freeman. Okay, so we will start 2 of the presentation with Dr. Mary, and Freeman will continue. So 10 minutes.
Thank you very much. So we've moved away from the wire and then the gauze and the things. We are coming home. So no wonder they put us at this point, the tail end, because we are talking about death. In as much as it will not sound so sweet to you, whether we like it or not, we all die. But how we die is very important to us. So as to how we are also cared for. If we are diagnosed with a condition like cancer, cancer is a condition that when it afflicts you, you want to find out, why me? And sometimes people think that I have led my life so well. Why cancer? Why me? So that is where the existential part of it is very important. And there are sometimes the medicine or the medical doctor will tell you that, I think at this time, we don't know what to do again. So where do we turn to? We turn to the Creator. So we feel that spirituality in cancer care is very important. So we sought out to explore nurses' lived experience with regards to spirituality in oncology care. And then this is a study that was done by one of the oncology residents from the Ghana College of Nurses and Midwives. So I supervise the study, but the student is the first author if you look into the brochure. All right. Please, the next slide. Oh, okay. All right. So we are saying that when you are diagnosed with cancer, you want to know the meaning. Why the cancer? Why you? You have so much uncertainties. Am I going to live? You also that is the time you want to find out, how is my relationship with God? How has it been? And we know that for cancer, because it triggers some of these issues in our minds, spirituality is very important, because that is where we find the meaning. Somebody will say, I think that God said He created us and He will test us. So it is one of the tests. So your test is what you have gotten as cancer. And God says that I wouldn't test you beyond what you can bear. So whatever you had is because God knows that you can bear it. But then we know what spirituality in cancer care has been in the advanced literature. But then in our part of the world, what pertains? So we sought out to explore what nurses go through when they want to deliver spiritual care in their course of duty. So we sought out to explore the central tension between nurses who are non-Muslims, they are caring for Muslim patients who are having cancer, And then nurses who are also not Christians. We want to see how were they able to deliver such care to them, because we all have our cultural values, and even in terms of the religion, we have things that we want to do when we are sick. Are we able to have them? Was I able to be allowed to use a handkerchief the pastor gave me? What of the back to sender oil? And also, what of the rosary? Did the nurse allow me to put it around my neck, or did the nurse pray before the chemo session so that the evil one wouldn't come and change the strength of the medication? So we were to explore this through phenomenology. With this study, you wouldn't see this presentation, you wouldn't see much of the usual quotations from qualitative study, because we are here to explore the essence of the phenomenon. How were the nurses, how were they experiencing the phenomenon of oncology, spiritual care in oncology setting? So you wouldn't see so much of those ones, so please pardon me. So I use the Husserl's approach to phenomenology. And then, yes. So Husserl is one of the authorities that has prescribed how to explore people's lived experiences. And then we sampled the views of 20. We interviewed 20 nurses. And these nurses were picked from the Kolebu Teaching Hospital across. There were nurses and midwives across all the areas. Shinad, surgical, radio oncology units, to be able to speak with them. And we use Colese's 7-step approach. So how did we analyze the data? We read through, these are all literature, so it might not be so much important to us. We have to move on. So the people we interviewed, we had 11 nurses and 9 midwives. Yes. And then majority of the nurses were females. It tells us how female domineering the profession has been. Then how did they experience the phenomenon? So we had 3 experiential structures: relational, ethical, tension. So the nurses believe it differs from what the patient believes it's all about. So the patient who is having cancer feels that if I am able to maybe recite this portion of the Quran, I will get a relief. But the nurse doesn't believe in that. And then the patient who believes that, oh, I need to read the book of Ezekiel, because in the Bible, this is what Ezekiel said. It was the bone, flesh came to, and then life. The nurse who is a Muslim that doesn't believe it. And surprisingly, the people we also interviewed, some of them were also not, they were neither Christians or Muslims. And they refused to also disclose their religious affiliation. So it tells you what the patient will go through. I'm neither a Christian nor a Muslim, and then you are here to, Then we come to systemic and institutional constraints. So within the institution, we don't have a registered imam or malam or a pastor or a chaplain who maybe when you are in difficulty, the person can come to your aid. Or maybe we are coming to start chemo session. We believe that spirits are around. Can we pray? There is it's a protocol for anybody to go through. So as and when somebody deems it fit, he feels that, can we pray? Because one day, one patient said, most of the time I feel that the chemo medication can be changed because the evil one can be around us. But I'm afraid to tell the nurse that we should pray before the session is started. Yes, but then that is what goes on. Then there is no privacy. There are other things you would want to do, but then there is no privacy. You want to do something. Either you believe you believe in the traditional African religion. Maybe there is some incantations you want to do. Will the nurse allow you to do it? Or maybe there is a verse in the Quran you want to do. Will they allow you to do that? You've been put on the surgical table. Would they allow you to do that? Yes, I remember a patient saying that when I was put on the table, I realized that I was closer to my grave. So I was turning around and I heard the surgeon singing, Asians of this, as old as you are. Yeah. As old as you are, you remain the same. Amen. All right. So that is what happened. Then we also have workload because the nurse has a lot to do. We all understand workload. So the nurse is not able to meet your spiritual needs because when my matron comes, matron wants to find out whether I've checked all the vitals. I have given all the administered all the medications. There is no a document for them to see whether I've met your spiritual needs. So what I'm going to be measured on is what I'm going to what? Deliver. So there is no such thing there. Then let's look at the collaboration. We have institutional chaplains. Sometimes we see pastors coming to the facilities, and some facilities they have it. A facility like 37, we have the chaplain, we have the imam, but the problem is the collaboration. So according to these healthcare professionals, they said they don't have that collaboration between them and then these spiritual leaders. So because of that, there is a problem. Now let's see the theme, relational and ethical tensions. That is where we talk about the patient belief, the nurses belief, and the professional boundaries. Because as a professional, ethically, you don't want to overstep your boundaries. You have to live or work within that remit. So this is where the nurses describe that as a restraint. And because of that, they adapted to it. They didn't want to. So it prevented them from being able to deliver that care. Now let's see, encountering existential distress. So the patient questioned the meaning of the illness and suffering. And some express loss of faith or disbelief in the higher power. That is when a patient told me that I have lost faith. I have asked my younger sister to bring me novels to read. Because since my secondary school time, I never fornicated. Up to the university level, why should I have breast cancer? So the patient feels God has disappointed. Yes. And then nurses experience these encounters as emotionally tension and difficult. So you are torn between, you don't know what to do. So in that case, because the patient asks these questions, why me? You lose the faith. And then you want to find out, is there any hope at all? You want to find meaning to whatever is happening. And sometimes you have to land somewhere in a spiritual home where you'll be told that maybe your sister came for your dress. So my client told me that my sister-in-law threw the breast cancer at me, so I have gone for the back to send her oil. And I will throw it back at her for her to also understand. Then we come to the systemic, the institutional constraint. I think we've spoken about this. The limited space, no privacy, private room for us to pray. Let's look at this. Strengthening spiritual care. What do? We need collaboration between the chaplains, the imams, the counselors, and then the wider team. So it's not nurses and doctors' affair. In terms of cancer care, we need to include these people in the multidisciplinary team. We need training. There should be a structured way. There is no way we can leave spirituality out. We need to incorporate it in our care. Then we also need to create private spaces for our patients to also have that connectedness with their maker. We need to live at peace with our maker even before we transcend to the next world. And then there should be protocols. Whether we like it or not, we need to have protocols. So the essence of the structure, so like I told you, you wouldn't see verbatim quotation. So what is the essence of the structure? So providing spiritual care in an oncology setting has been what was lived as an enduring commitment. Because I don't understand what you want. You also don't know. There are some people who even feel that as for maybe this particular religious people, you are not supposed to touch them. But you owe a duty to the patient because there is what? A duty of care. You owe a duty of care to the patient, and for that matter, you need to do it. So they live this and they have to balance it to be able to have that presence, provide that compassionate care to the patient. So what does this mean for our oncology practice? Moving on. Yes, there should be relational care. we should allow time and space for meaningful patient-nurse interaction. Aside me coming to give you education, aside me giving you your medication, we need to do this. There should be competence. I'm a nurse. How do I deliver that care? So we need to train nurses in spiritual assessment. And with this, I know the palliative care nurses, they do it. I think we should incorporate it everywhere, not even in oncology or palliative. To be able to communicate, what do I believe in? In times of stress, who do I lean on? Then the systems, we need to be able to develop protocols, document and structure referral pathways, because if it is above you, please, you are not a priest. You have to refer the person to the appropriate quarters for the person to get that care. And then we need to be culturally responsible too. So at this time, if I am a Muslim and I have to go towards, refer the person to the Christian or the chaplain to be able to do the work. All right, so recommendation, we are supposed to develop, like I say, develop protocols to be able to do that, provide education to nurses, and also strengthen our collaboration with these people. We don't necessarily have to work among pharmacists, nurses, and others. And create confidential space for prayers, reflection, and spiritual support where feasible. And also embed spiritual care explicitly within our undergraduate nursing, because it's not there. Bruna insists that it's there. Culturally sensitive, but unfortunately, it's not all the institutions that embed it. And I think that we need to do this very well. So in conclusion, spirituality in oncology care was experienced by these nurses and midwives as relational, ethical, and also structural. So the take-home message is that, spiritual care is not a discrete intervention. It is a negotiated, relational, and context-dependent dimension of our holistic oncology care, because oncology care is holistic. It embodies all. Thank you very much. We'll move to the second one.
I think we have, should we do the second one? Yes. Okay, then 5 minutes. Okay, because
for which one?
The second one.
Oh, no.
It can't be.
10.
No, if I this one, you use 15.
All right, so
kindly do it in 5.
All right, so thank you very much. So dovetailing into this, what does it mean to die well? Because it will be a year, and I knew only the papa. So we'll all die. So what does it mean to die well? So we seek to get the views of family caregivers who are taking care of their family members in a teaching hospital. This one, not in Accra. Their perspectives of good health, good death. And again, we use a phenomenological study, because universally, good death has been explained in other jurisdictions as maybe having either the dog you love so close to you, caressing the dog, or maybe families visiting you in the care home before you die, all sort of things. But then there is a gap. And the gap is that, what is good death? Maybe if I should ask what is good death, I will hear all manner of things about what good death is all about. So that's exactly what we sought to explore. So we were looking at the suffering. So we want to look at suffering, how caregivers understand suffering, comfort, and peaceful dying, and then all to dignity and culture. So we use a phenomenological approach, and this time around, we use the analysis. We didn't use Colese's approach. We use George's approach. And we use purposive sampling to sample people who were actually having relations. Some died, some they were about to go, to find out what at all do they see as good death. So this is the demographics of the people who we interviewed. So we had 17 family caregivers. 14 of them were males, and then 3 were females. It tells you the caregiving abilities of women. And then the conditions, the people's relations were mothers, daughters, elder sisters, spouses, and in-laws. And the conditions that people were having, we had breast cancer formed the majority, liver, cervical, and then rectal cancer. So there were 4 dimensions of good death. So we have dying with less prolonged suffering, comfort, reduced pain, peaceful death. We have spiritual readiness, prayer, praying, reconciling with your maker, and being accepted by your maker, knowing that this time around when I go, I'm going to meet my maker in peace. Dignity and relational presence. Were the family members around? Where are my colleague nurses? Or you sacked the wife when the man was about gasping. Did you allow the wife to stay closer? And you ask yourself, if it happened to me, will I be okay? Was the person dying in the full glare in the open ward, or did you change for family members to be able to visit? In which circumstance were they dying? Did you leave them on screen and visitors were just passing by and watching them? And did they defecate on themselves, or you clean them before they die? Very, very important. Did you involve the spiritual leader? Did you ask which faith they belong to? Did you call the imam? Did you ask a Muslim to stand by to be reciting for the person to be able to also recite, which we believe that in that case your soul is accepted? Or did you call the chaplain? Then we have the cultural moral meaning. So the social expectation, you shouldn't struggle before you die. Yes, all these things were things we got from the participant voices. So longing for death without prolonged suffering. Sometimes we just wish she could rest peacefully and eternally instead of continuing to go through the pain every day. So avoiding unbearable pain, fear of prolonged illness, watching suffering as emotionally distressing. So it tells us that the medications are palliative care professionals. Please, we need to give them. Now, seeking spiritual readiness and acceptance. So it's a continuum. We need to pray. We need to have our reconciliation connected to our Maker. It's from Him we came from and we are going back. What is our relationship with our Maker? Have we been accepted? There are at a point in time you pray and realize that this time I think that God has heard me enough and God has forgiven me. And then readiness. At that time, the person is prepared to go. So if you haven't done this and the person is there, is not going. Some people, they have wishes. Let them fulfill their wishes. As soon as you take them through, they will go in peace. And it's very, very important. So the person said, as the condition became worse, we started praying more and preparing spiritually because we knew death could happen anytime. Now, preserving dignity and relational presence, kindness, privacy, compassionate care. Were you comforting them? Were you respecting them, the names they were having, or that patient? Were you giving the person the rightful appellation? Preserving dignity, personhood, despite dependence. So whichever respect you are according the person, you accord the person, even on the dying bed. Then the family at the bedside. That is where we don't do well. The moment you realize that the person is about going, we sack the relatives. And then the wife said, my husband all these years has promised to give me a ring. But then the day my husband was about going, I knew. I came to the hospital, but the nurse refused allowing me to sleep there. The following day, I came to meet an empty bed. The husband was gone without a word of bye-bye. Very sad. So all these things are things we found. Now, in terms of interpreting death through cultural and moral meaning, somebody said a good death was interpreted through family, spiritual, social expectation. This is not a quote. So we see family obligations. We should be there for them because we are parting ways. Let's allow the patients to be there. Social expectations that you are not supposed to see you in some circumstances before you die. So can you change my word for me when you realize that I'm about going so that people don't come and visit and see me? And then peaceful dying so that whether it is good or bad, it is interpreted according to culture. Very, very important. So dying was a social and moral transition, not simply a biological or biomedical decline. So what the four themes mean? It means is that good death has different dimensions. So dying well emerge as a peaceful, relational, spiritual, cultural, meaningful, and minimizing suffering while preserving personhood and connection. So the implications of the study, we are supposed to assess patients and families and ask them what dying well means to them so that we can be able to meet their expectations. We need to also communicate. We should include the family, spiritual and cultural priorities, know their spiritual and cultural priorities in end-of-life conversations. Very, very important. But we shy away from it. The nurses, we do better. The doctor is all apologies because you run away and leave for us to handle. Support. We need to address suffering, emotional distress, and caregiver needs, not symptoms alone. Palliative care professionals, please, we need to be there. It's not about giving the morphine and then the trauma though. We need to involve the right people. Then individualize. Yes, if I am a Muslim, I need somebody who can stay with me and be able for me to take the tashahhud, ashhadu Allah ilaha illallah, for me to know that now, if I die, I'm going. So me, if I'm driving and it becomes crazy, I start to take tashahhud before I move. Yes, and I believe Christians also have things that they should be able to go through whilst dying. But unfortunately, many people have died without reconciling well with their maker. And I think that we need to do well. So in all, we believe that a good death is more than symptom control. And this our Ghanaian setting, the caregivers, the context is important, the culture is important. But we know that dying well in our Ghanaian setting means that it's relational. You need to tailor it to the culture of the individual and the culture with the religion embedded. And palliative care should not protect comfort, dignity. Should protect comfort, dignity, family connection, and spiritual readiness. Very, very important before we go. The question is not how do we treat, but also how does dying well mean to this family? Thank you very much for your attention.
Thank you so much, Dr. Idrisu. I think she has summarized it very well. So she has indicated that in the treatment or management of a patient with a condition, the presence of the family is so important. There should be dignity, respect. There should be the spiritual aspect of the treatment. And all of this need to be present when managing a patient with a condition. Thank you so much. We will now invite our second presenter.
Good afternoon. My name is Oseitu Firma. I'm a palliative care nurse specialist. Slides, please. And a lecturer at Wisconsin University School of Nursing. I know we are all tired, we are hungry, but bear with me, I'll try and speed up. All right. I'm coming to talk about negotiation ethical boundaries, nurses and midwife perspectives on legalization of euthanasia in advanced cancer care in Ghana. Euthanasia means mercy killing, assisted dying. Next slide, please. This will be the background of my presentation. Euthanasia has been one of the debated issues when it comes to end-of-life care, raising a lot of concerns when it comes to ethical issues, legal issues, professional concerns. Although euthanasia has gained global recognition, there is limited research for us nurses and midwives when it comes to our perspective. And the existing studies basically is naive. It's focusing on the physicians, the legal perspective, and the public attitude with less attention given to nurses and midwives. For patient preferences, when it comes to either going for mercy killing or euthanasia, we realize that it's highly affected by the family's choices, their spirituality, and also their moral choices as well. So I believe that understanding these perspectives, because nurses and midwives, we play the role when it comes to taking care of our patients with advanced cancer, our study sought to explore nurses and midwife perspective, ethical reasoning, perceived implications regarding euthanasia within the advanced cancer care in Ghana. The methodology of my study, my co-author is also here with us. We did a descriptive qualitative study. We conducted interviews among 24 nurses and midwives across Ghana, the northern, the middle, and the southern. We used 6 healthcare facilities, the teaching hospitals, the regional hospitals, and the municipal hospitals. A semi-structured interview was conducted either face-to-face or virtually between April to August 2020. And reflective thematic analysis was used to analyze our data. We took our ethics from Noguchi Memorial Institute of Medical Research. For the eligibility criteria, nurses and midwives who have ever worked in the oncology care was included in our study, and we excluded nurses and midwives who are doing their clinical rotation or placements with limited exposure to oncology care. To the findings of our study, out of the 24 participants, 20 were females, 4 were males. The ages was ranging from 28 to 46. The ranks were the staff nurses, the senior staff nurses, the principal nursing officers, palliative care nurse specialists, oncology nurse specialists. Their clinical experience was between 3 to 16. Most of the nurses and midwives were having their bachelor's degree, few were having their masters. With their religion, out of the 24 participants, 19 were Christians, 4 were Muslims, and just 1 was a Buddhist. To the findings, we had 3 teams and 6 sub-teams. The team 1, which talks about the support of euthanasia legalization, the sub-team is personal encounters with patients suffering. So the midwives and the nurses made us understand that if patients with advanced cancer is having unbearable pain, they should have a choice to choose, and the choice is either assisted dying or euthanasia. It's supported by a quote by James that I read. I often felt helpless. They suffer so much, but sometimes I see their eyes bleeding for relief. Legalizing euthanasia would allow us to offer a compassionate choice for those with unbearable pain. The second sub-team of Team 1 talks about promoting patient autonomy, where the participants emphasize that we should let the patients have the central role when it comes to taking the decision of what euthanasia. Nana said patients should have their final say in their treatment, especially when it comes to unbearable suffering. However, some of the nurses and midwives had reservations with the extent of the autonomy given to euthanasia. And Adjoa Mensah said, based on my belief as a Christian, I don't give life, and there is no way I can take life. I'm not in support of euthanasia. The second team is concerns and considerations. A sub-team is ethical and religious consideration. Most of the participants had concern when it comes to the legalization of euthanasia, and the concerns were based on their moral principles, patient vulnerability, professional responsibilities, and possible unintended consequences. I read the quote by Nanaya that says, "Part of my concern is about healthcare professionals themselves. Are we prepared to handle the emotional and the ethical weight of being involved in a decision that ends somebody's life?" So the second sub-team from Team 2 talks about requirements for comprehensive guidelines and safeguard. The participants who supported the legalization said that we need to have a strong regulatory framework and guidelines for euthanasia practice in Ghana. Nanaya also quotes, "We need independent review in place. Decisions should not solely rest on practitioners involved. A third party can ensure fairness and help avoid any conflict of interest." The last theme talks about practical consideration within the healthcare system. A sub-theme that we identified was financial implications and resource distribution. The participants' view were that legalizing euthanasia has implications when it comes to healthcare delivery, resource allocation, and end-of-life services. Linda said that we must ensure choosing euthanasia doesn't become a preferred option simply because it's financially easier than providing a comprehensive care for those with terminal illnesses. The last theme, which is theme 3, and this sub-theme 2 says that palliative care options and alternatives should be considered. Most of the participants emphasize that we need to strengthen palliative care services, and it should be our priority when it comes to managing patients with end of life. I read a quote from Georgina that says we need to ensure that participants are aware of their choices. Many may choose euthanasia because they don't know about the full spectrum of palliative care available to them, which can effectively manage pain and other distressing symptoms. I'm concluding by summarizing our study with implications for clinical practice and professional ethics. I'm saying the experiences of prolonged suffering, pain, physical deterioration, and loss of dignity may influence our perception when it comes to euthanasia. There should be a need for a structured ethical reflection, communication, and palliative care education to help professionals navigate end-of-life dilemmas. Healthcare professionals must also undergo continuous training on ethics, advanced care planning, end-of-life communication, and culturally sensitive palliative care for our patients with advanced cancer. The findings highlight the need for an ongoing dialogue among healthcare professionals, patients, family members, policymakers when developing end-of-life policies. Thank you.
Okay. Thank you so much for the presentation on a very complex topic. And in fact, this topic is culturally sensitive. But as researchers and as professionals, we always want to learn more. So we always want to understand how things work. And she has laid a very good foundational presentation on that. Since time is far spent, I'm going to invite 2 questions. Then we can go for our break. Okay.
Okay, thank you very much. My question has to do with Doc's first presentation on where she emphasized that spirituality is also must be incorporated in the treatment. Okay, so I want to find out in the event that we are working with this framework where the spirituality conflicts, there's some kind of confliction with the treatment. You get in our Ghanaian context where people have a lot of funny things about spirituality. So I want to know, how do we go about that?
Okay, Dr. Mary.
Thank you. She made the question easier for me by saying that it conflicts with the treatment. I think that one, it will be a no-no. It's about explaining to them the import of the treatment. But then, in case it is to you, the nurse, you have ethical principles that guide your practice, and that is what you go through. Thank you.
Thank you. Auntie Comfort.
Mine is a contribution by the positive way the spirituality aspect also helped me. I started from Ridge and I was referred to the surgical department. So I had my surgery before coming to the radiotherapy department. And when I was asked to come there, I didn't know what I was going to do. But after I've been spoken to, I was asked to be taken care of by Dr. Aite. Honestly, I came there weeping. It was all weeping. Then I asked, can I survive? Then she told me, we are just tools. We, the doctors, are just tools in the hands of the Lord. It is God who is going to heal you. It was at that point that I realized that no, if the doctor is telling me this, then I better look up to God. So I did it in two ways. Adhering to whatever the doctors were telling me to do and make sure I was doing it, even though it was a bit difficult. And also having that kind of faith and trust in the Lord that so for me, it's very important. It helped me. If I'm surviving today, I know there are some people here, and TJ, most people who help me, yourself. But I believe that the final appreciation, I would say, goes to God. So our confidence and our faith. So that spirituality aspect is very important. That needs to be taken care of.
Wow, thank you so much. I think, okay, I will take the final one. No, it's lunchtime, so you take a contribution. Okay.
Good afternoon once again. Ajia, God bless you. I really loved your submission. Now, you share from the beginning now, BC area. Senia, Makika, Munsa Muni na say. In fact, Munimuti, na Munim Yamoye, Nyakupon Shamunina. Pepacho, to what Auntie Connie said, spirituality and cancer. Some way for, but ye diagnosis na pressure until now. If you say Psalm 118 verse 17 says, I shall not die, but live. What are you living for? To declare the wonders of the Lord. I also asked the doctor that, can I survive this? Because looking at, I was in stage 4. I asked, can I survive it? And the doctor told me there are 4 things in surviving cancer. If I will be able to follow it, I will survive it without any medication. And I said, okay, I'm listening. I say, have faith in God. Having faith in God is not just, God, I know you heal me, or read the word, pray, eat well, exercise, live a stress-free life. I was like, oh, really? Is that all? See, okay, that's all. So, if you know, I made a practice. I was supposed to have graduation. Made in yes way. 3 years now. I am not boasting because it is from grace. It is not my work. I don't take medicine. The only medicine I take is the Wema. Yes. I don't go for review. I don't go for any, don't say, hey, the Lord has done it. I don't go for anything. And if I tell you that I'm even having kata, and it's just normal kata. So spirituality and cancer, they link.
Okay. I wish we had enough time to discuss this topic, but since we don't have enough time and it's time for lunch, I think we'll bring the curtain here. So the conclusion is that spirituality and dignity, comfort is very important in the management of cancer. And as healthcare professionals, we must ensure that we provide these services. I have an important announcement. So from here, we are going for the lunch break. After that, at 2:15, we are coming back to the main auditorium. That's where we have our business meeting. After that, we are going to
Please don't worry if you don't have a coupon. I shared some coupon and it's not enough, but you all have food to eat. Okay, so when we are done here, we just move to the canteen. Okay, please, the rest.
Please, can the presenters come in front for a group picture? The presenters kindly come in front for a group picture. All the presenters.